you'll have to mute yourself because you're signing in through Polycom. Otherwise, there'll be feedback.
That's fine, we can do that.
Okay.
Okay, we can do that.
Okay, can you hear us now? Not?
Okay, there we go. Yes, okay, there we go. So my name is Patty Swagger, and I'm with the Nevada Geriatric Education Center. We're a program of the Sanford Center for Aging at the university. And our mission is to improve the healthcare that's delivered to older adults. We don't work with older adults directly, but rather indirectly, because we provide education, information, and resources to healthcare professionals, caregivers, faculty, and students in the health professions. So today's program, we have effective interventions to enhance well-being in the veteran living with dementia. So is everyone in the right place? And is everyone signed in? And we all have evaluations? Great. So I want to encourage you to mute your cell phone or turn it to the off position. We don't want to distract our fellow participants, and we also don't want to distract the speaker. And in this kind of technology, we get feedback, as you all have experienced, once we get that sound. So we appreciate you doing that. We do have approvals for long-term care, physicians, nursing, social work, where the marriage and family therapists are still pending. Is there anybody in the audience? And we'll get back. We'll get that certificate to you after. For those in Reno and Las Vegas, we do have certificates available today, so we'll exchange your evaluation for that certificate on your way out. And for the Zoom participants, for the participants in ELCO, then we'll just give you your certificate after you completed and sent your evaluation to us. So once again, for all the sites, we'd like you to mute your system. We have Troy here, who's going to help navigate. Raise your hand on your computer or phone or in the visual screen so that we can know that you want to ask a question. Jeannie tends to be very interactive, so appreciates the interruption. She'd rather you interrupt her with the question that you have on your mind at the moment than wait, okay? What else? So I'm going to introduce both speakers today. First, we have Jeannie Clark, and then we have Fred Wagar. Jeannie is a retired geriatric nurse practitioner. She also maintains her registered nursing license. She worked at the VA for about 15 years here in Reno, and she worked in what's called now the Community Living Center, which really is a broad spectrum of care. So they offer hospice care, rehab, long-term care, etc. So she's got that breadth of knowledge, and she'll provide some great examples along the way. And then she also worked at the Washoe County Health Department, and so she did outpatient care there. So I found Jeannie to be just a wonderful resource because we love her so much. She's taught for us many times at the Geriatric Education Center and has also done some teaching at the university. So I think you're in for a treat. I get the pleasure today to meet our next speaker, who's Fred Wagar. He's a retired Army veteran. He began working with the veterans in 2001. He's a life member of the Disabled American Veterans, the Veterans of Foreign Wars, and the American Legion. Currently, he serves as the Nevada Department of Veteran Services, Deputy Director of Programs and Services, and he also represents the agency who sponsored today's event. So we are pleased to have Wendy Simmons here, who also represents that agency, and so we're pleased to have their support, and so glad that all of you are here today. So I am going to turn it over to Jeannie after we give her a warm round of applause. Thank you.
I'm gonna wait until my slides are up. Ta-da! Okay. Hi, everyone. Welcome. I would like to just take a moment to check with Elko and Las Vegas, just to get an idea of who is in the audience that I'm speaking to. If we could do that, I would be real appreciative. If you can help me with that.
Go ahead, Elko.
Elko, could you just kind of chirp out if you're nurses or social workers or psychologists or recreational therapists or who you are in the audience? You'll have to take yourself off mute for a minute, though.
No, they're off mute.
Okay.
Go ahead.
Okay. Elko? Hello? That's not going anywhere.
Wave your hands if you can hear us.
Can you hear me? If you can, wave your hands. Ah, yay. Okay, now could you open your mouth and just holler to me, just kind of one at a time, what you do that makes you interested in this course? Like, say, nurse or social worker or CNA? Nothing's happening.
You hear a little something.
Okay, well, I'll leave it.
Raise hands, nurses, raise.
It looks like Ellen might have gone over there. Troy, does that?
Yeah.
Okay.
Can somebody say something just so we can test that we can hear you?
It looks like the gentleman in the back is saying something,
Oh,
Okay.
okay.
All right, we have a hearing problem and it's not just mine, so we'll work on that and then we'll get back to you. Thanks. How about Vegas? Any chance you can have Vegas chime in and tell us?
Can you hear us?
Yes.
Yes.
Vegas can hear us. Okay, well,
Social workers? How many social workers? Raise your hands.
oh, look, I see people.
Okay.
Yay!
And
Okay,
one nursing, case management, nursing home administrator, RN, case management, nursing home administrator.
great. Thank you very much. I'm so appreciative. Okay, now we'll just, unless we can get something from Elko, we'll just move on.
Oh, wait, we can hear Elko.
Oh, we can hear Elko now. Okay, yay, Elko. Can someone just kind of give a synopsis of who's in the group?
No, wait, oh, no.
Okay, well, we'll start then and maybe we'll catch up to that later. So,
Dial-ins too.
I know, but we don't have the time to do all of those. The dial-ins are very significant, but I just
They
need
could
kind of,
do their little closed caption thing or whatever it's called to Troy.
The chat, yeah.
The chat,
You can do the chat function.
okay, that'd be helpful if you could. Thanks. So the title of my talk, Effective Interventions to Enhance Well-Being in the Veteran Living with Altered Cognitive State. I just want to spend a minute talking about that title. It sounds like a heavy-duty title. And I want to tell you, I've been giving this talk or something similar to this for well over 30 years. And this is not what it used to be called. It used to be dealing with difficult patients, dealing with challenging behaviors of dementia patients, dealing with interventions for combative patients. And you see a theme there? It's negative. It's all negative. And unfortunately, that was the focus 30 years ago. We focused on the aggression or the combative behavior, the challenging behavior, not really recognizing that it put a certain mindset in the participants as well as anybody else on the staff that these people then were difficult or combative or challenging. And that's not the message that we want to give in this day and age. We want to really put our focus on what we can do to promote well-being in people with an altered cognitive state, i.e., one example would be dementia. Another example might be people who have had strokes, multiple strokes, and several other diseases that may cause people to have some change in their cognitive abilities. When you say a person with symptoms of dementia, that kind of takes you down one road. And then if you say a dementia patient, that takes you down another road because you're putting a focus on a medical diagnosis and all the baggage that people think go with that diagnosis. So I just thought it was important to point out the transition in this talk over a period of years. So responses and reactions communicate what words cannot. And if you're looking at this picture of this woman, what do you see? What strikes you about her? Somebody said describe this woman. What terms might you use?
Frustrated.
Okay. Others?
Despair.
Could be confused, hard to say if she's not talking to you. Despair, whoever said that, that's excellent.
She might have even the pain.
She may be having pain, absolutely. Anything else?
She's not happy.
Very good, she's not happy. So you can pick all that up from looking at this picture without the person ever saying anything to you. And that's why we have to be really hyper vigilant when we interact with any of the persons in our care. And it may be people in long-term care, it may be people in assisted living, it could be, you know, your spouse that you're caring for in your own home, it may be someone in the hospital or someone in their own home that you're out visiting. You really need to make sure you look at the whole picture. So remember that dementia is a shift in the way a person experiences the world around him. And that's a positive way to look at it. They just no longer perceive the world the way they may have 10 or 20 years ago. It should be viewed as a change in their ability, not a disability, so that they now have different abilities as far as engaging with people and their environment. Distress is not the problem, but it's a symptom of the larger issue. For example, if you have somebody who's coughing, it would not be prudent to just treat that cough by giving them cough medicine. Or if they were complaining of chest pain, you wouldn't just want to give them a pain pill. You really want to find out what the larger issue is. Because if you don't do that, they will decline and they could possibly die, particularly if the cough was related to pneumonia and the chest pain was related to myocardial infarction. So you really have to, again, look at what is our goal here. Okay? People with dementia are capable of learning new skills to adapt to their changing perceptions. And that's really important to remember. They express themselves in their own unique way. What I have found is that persons with dementia are often put into situations with an expectation that they will perform the way they did 10 or 15 years ago. And they can't. They don't have the ability to do that. But when you put them in a situation where you expect them to perform that way, they then become frustrated, they may become angry, they may become just very, very upset, they may just shut down. And then oftentimes, if it's the frustration or the lashing out or the anger that rears its ugly head, then people want to say, oh, this behavior is not acceptable, we should medicate them. And yet we've really put them in the situation to cause this reaction, and we should have known that at the time. So, okay. I don't know how many of you have heard of the Eden Alternative, but they really have done a lot of work with patients with altered cognitive state and try to find a way that can promote well-being in persons with dementia. And G. Allen Power, I don't know how many of you have read his book, Dementia Beyond Disease. It's just, I think, the best book out there for teaching this new way to look at people with dementia or altered cognitive state. And one of the things that came out of his work with the Eden Alternative was the 7 domains of well-being. And the premise is that if all of these things are put in place, that is how you promote well-being. And if 1 or 3 or 5 of them are not being nurtured, then you see a behavior that attempts to communicate their displeasure or their need, and they don't always have the words to do that. So identity is being me. And for instance, if I was a physician, I might identify with that, and I might want you to identify me as that. And therefore, I might want you to call me Dr. So-and-so. Or I might want you to call me Joe. And so one thing is to talk to the person and say, and this is what I always did, hi, Mr. So-and-so, or hi, Dr. So-and-so. My name is Jeannie. I usually was very informal and asked them to call me Jeannie. I didn't say Mrs. Clark. And then I would say, what would you like me to call you, or how would you like me to address you? And whatever they told me, that was the way I addressed them thereafter. And, you know, there was a huge variation in that, but I tried to help them identify with who they were. Okay, connectedness, it's being with. And we all need to feel that we're connected to something or someone. Security is how we find balance. And as we get older, that may be more difficult if we're no longer living in the home that we were in for the last 30 or 40 years, or not with our spouse, or our children are no longer close by, or our neighbors are no longer there, et cetera, et cetera. Autonomy is our attempt at seeking freedom. Freedom to make choices, freedom to disagree, freedom to go where we want to go and do what we want to do. Meaning means that I need to feel like I'm making a difference in someone's life, whether it's my children, my neighbor, the people in this class, my grandchildren. That's what gives me meaning. Growth is growing and developing, and we continue to do that throughout the spectrum. Even in early and middle stages of dementia, we can do that. And joy is what it's really all about. That's what we all seek, and that's figuring out a way to have fun. Now, there have been other people who attempted to come up with ideas on how you can get well-being. And Kitwood and Breeden came up with these 4 states of well-being. And if you look at the little parentheses, they really mirror what was in the 7 domains. So a sense of personal worth, sense of agency, social confidence, and hope. And then we have Kitwood's 6 main psychological needs, and he envisioned this as a flower with 5 petals, and the petals were comfort, attachment, inclusion, occupation, and identity. Again, very similar to those 7 domains, and the center of the flower was love. Now, what do we see when we look at this lovely lady? What do you read from looking at her?
She's enjoying.
Happy.
Happy, right? Engaged, right, with her duck. Anything else?
She was, I think, for this.
Yeah, she does look like she's showing an interest in the duck. Anything else? Maybe you'd say joy or satisfaction. And she's nurturing this little duck, which is giving her some meaning to her life. So cultural change. Cultural change, I think, first came on the scene 15 or 20 years ago. Care plans, nursing care plans really used to be more medically oriented, if you would recall, so that they dealt more with the medical diagnosis. And so you might have a problem like patient is combative during personal care.
Could I just stop you just one
Sure.
second really quick? Sorry, I have to make sure, because Vegas isn't able to see the slides.
Okay.
She emailed them to us.
Vegas, can you hear me?
He raised his hand, yes.
Okay.
Okay.
Are you seeing this? Are you seeing the slides now? No? Now? Any luck? Nothing?
No?
No luck? No slides? Okay. I'll have Alan RIT call you. We'll try and figure this out. Sorry.
Hopefully they have their handouts and they can follow those.
You know, I didn't see a lot of papers.
Well, I saw a few.
Unfortunately, most of them did not bring their backups.
Okay,
I'm holding on to Zoom right now,
Okay.
okay. Thank you.
but, okay.
What?
Go ahead.
Go, okay.
Yeah.
So Goal would be no aggression during undressing or bathing, and the intervention would be maybe undress in the bathroom. That's the old model. So in the person-centered model, you're really thinking of the person and phrasing things from their perspective, but often that was done without any input from the person that you were delivering the care to. Then we went into person-directed care, which was an effort to ascertain the person's own direction or talk to someone in the family and find out what they liked, what they didn't like, what was upsetting, what wasn't upsetting. And finally, the very best one is relationship-centered care. That's the best care that can come within the context of meaningful relationships. And what we really are talking about here, if the person is not living at home, is dedicated staff. Okay. Now, I know back when I worked at the VA, that was a dirty word. People did not like the concept of dedicated staff. The staff felt like they needed to move around. They didn't want to have to take care of Mr. So-and-so every day or Mrs. So-and-so every day. But you're really not putting your residents' best interests first if you're switching the staff around. And there are many, many advantages to having dedicated staff, which I'll go into in just a minute. But from the standpoint of person-directed or relationship-centered, your care plan might, written again from the perspective of the person that you're caring for, I need to feel safe and warm when I have personal care. So that would be your problem. And your goal might be, I need to feel warm and protected during bath time. And then your plan would be undress me in the bathroom and keep me covered up. And that just, it sounds very positive that way. You're not saying keep them from being combative or, so it's no negative. It's all positive comments with this person stating what it is they need to feel safe. Okay. I'll get down to the dedicated staff here in a minute. But first, let me just give you a few more tidbits on these various domains. Identity. People are struggling to make sense of today. And I love this, but they're only being offered yesterday. So you can't have an expectation that they'll remember what they did 5 years ago or last month, or that they can perform the way they did then. You need to just take today and offer them an opportunity to make the best of today and try to understand who they are and where they're coming from. Connectedness. If you're in any sort of a residential facility, assisted living, an independent living, a long-term care, you need to have dedicated staff. Otherwise, you miss cues. And it helps the person to feel included. And you, as a care provider, can make observations about what's going on. And sometimes, instead of asking questions, you can make an observation. Like if it seems like the person's been troubled that day or crying a lot that day or maybe lashing out, then you might just make a statement like, it's been a tough day today, without actually asking a question and then giving them an opportunity to think about it and make some comment on that.
So Amy, they in Vegas, they said you just dropped, you're no longer there.
Oh, I'm not there either.
You're here, but you're not all there.
Yeah, I think Natalie is switching over. Is that what's happening?
She says, we can see the slides, but now we can't hear.
I can't hear.
Yeah, see, Fred just told me that too.
We can only hear you through the polyphone, that's what she said.
Alan, can you hear us? Okay, he's working on it. Thank you.
Shall I continue? I'm sorry for Vegas.
They can't hear you.
It's really difficult to be on that end of it. I've been there and it's very difficult. So I have been in a position more times than I could begin to tell you in my career of making observations because I happen to know the person who was involved. If you want to call him patient, if you want to call him resident, client, whatever terminology you're familiar with. But being familiar with them is what makes a difference. So I have had people with a change in their persona. They're usually smiling. They usually like to get up first thing in the morning and get their makeup on or get their shaving done and get dressed. And you come into the room and they're in bed and they haven't done that. If you don't take care of that person every day, you don't know that that's a change in their behavior. You don't know that that's a red flag. I had a patient once, this was in the outpatient arena, and she was 76, bright as could be. She worked full-time for Western Union, and she drove her car, and she bowled 3 nights a week. I'm talking very active 76-year-old woman. And she came in to see me in the clinic that day for her every 3-month blood pressure check. And as we were talking, I noticed that she seemed to stumble over some words, and then she had trouble processing questions that I would ask her. And that was a huge change for her. And so I said to her, Martha, I'm a little bit concerned. You seem like you're having trouble processing some of what I'm saying to you. Have you noticed that to be a problem? And she started to cry. And she said she was driving home from bowling the night before, and she didn't remember where she lived. And she drove around for an hour trying to find her apartment. Now, that clearly is not dementia, because dementia doesn't occur that quickly. And that leads you to believe it's some sort of a delirium or some sort of a disability or distress that's occurring that's giving you this very recent change. So we sent her off for lab work and a CT of the head, which showed a huge brain tumor. And that was the first inkling that I had. But if somebody else had seen her that day, they probably wouldn't have given it a second thought, because we had 76-year-old patients who weren't as sharp as Martha and didn't necessarily process all information as quickly as I knew she could. So again, big deal. 99-year-old patient who read the Wall Street Journal every morning at the VA. Delightful gentleman. And one day I just said to him, Mr. So-and-so, how was breakfast today? And he said, boy, I didn't sleep well last night. And so then I said, what are you going to do today? And then he said, don't mind if I do. And I thought, wow, this is not him either. But again, I knew him. I looked at him, and the first thing I realized is he didn't have his glasses on. And then I thought, well, if he didn't have his glasses on, I wonder if his hearing aids are in. And they weren't in either. So when I put his glasses on and put his hearing aids in, and we do need to be sure that the hearing aid batteries are working, because that's another issue. As soon as I did that, I repeated the question and said, how was breakfast this morning? And he said, oh, it was great. We had pancakes. But someone else would have thought that there was a problem. Well, there was, but it was much simpler. It wasn't some, major infection or whatever. So some of the other things you can do is to focus on what abilities they have. Make that connection with them. I know that my patients at the VA knew me, and even people who were in end-stage dementia, if I walked into the room, there was an acknowledgement on their face that it was me. And if I was gone for 2 weeks and I came back and walked in the room, they acknowledged that. And so some people will say, well, they have dementia, they don't know the difference. They absolutely do. And it just makes such a change to them. Sometimes you can give them a body pillow, or you're all familiar with that. When my husband died 5 years ago, my dearest friend brought me a body pillow that night. And it made a huge difference, because I was not used to sleeping in an empty bed, and I was used to spooning. And I have to admit, the pillow didn't give back the warmth, but nevertheless, it still made a difference. It was an important thing. Now, in Power's book, he says that one of the patients said over and over again, I want to go home, I want to go home, I want to go home. What do you think they might mean by that?
So I want to go home could mean I want to go home up to heaven.
Anything else?
Sometimes we don't even know, because I had a lady who says, I want to go home, but home is our facility.
Okay, I'm glad you said that. So most of the time if someone says, I want to go home, they don't mean to their house at 1313 Bluebird Terrace. They mean they want to go home where they feel protected, secure, nurtured, recognized, acknowledged, familiar, comfortable. That's what home meant to them. And so oftentimes they're trying to say those things are missing from their current environment. And they want you to do what you can to put those things in place. And one of the ways you can put that in place is with a dedicated staff. Again, they can provide those things that are missing. So don't always take them literal, because indeed the assisted living or the nursing home may be their home now, but they're missing what's lacking in that environment. Okay.
There's also one example to that.
Yes.
You also have to know your resident by
Yes.
heart, because I had one resident who's a nurse. She's a retired nurse, and she was a nurse all her life, and she always wanted to go home. So and then once I told her, you're not going home because it's your duty today, you're on duty, you can go home tomorrow. So she will stop telling that she's going home, because she knows that, we pretend that she will be in charge. So she stays.
Yes.
And then tomorrow she forgot.
And sometimes you can do that. Sometimes that is an acceptable alternative to redirect them or to give them something that will take their mind off what they're talking about. And that can be an approach, absolutely. But it's also an important approach to find out what it is that they're lacking in their environment, which will then make them happy to be where they are. So I think both of those approaches are very important. Security, again, familiarity diminishes when you're in a new environment, and so then you have fear and doubt. And you need to know that you're still there. You're still a person, you're still recognized, you're still validated. Have people walk with you instead of having an expectation that you're going to sit in a wheelchair or a chair all day. When my father had to go into a nursing home for the last 3 months of his life after his second stroke, and my mother was not able to care for him, he was 90. He was able to walk even after that stroke with help of a walker, and he could certainly stand and pivot and get into a wheelchair. And yet every time I went to visit, he was sitting in a wheelchair and people were wheeling him to the dining room, and they were picking him up out of bed and putting him into the wheelchair. And there was no reason to do any of that, because he had the capability of standing and transferring into a wheelchair and walking behind the wheelchair. And so those attributes that he possessed when he was admitted quickly declined. I was there for an hour twice a day, but the rest of the day, those things weren't being done, because people make assumptions that if somebody's had a stroke and he was confused, so gee, must have dementia as well, he's not capable of doing any of that, even though it was listed on his care plan and in his record. So again, they don't want to do a disservice to our patients or these people. And we don't want to label them. That's another thing that many people do. Oh, she's difficult, or she cries all the time, or she gets angry, watch out. And keep in mind that those veterans with PTSD, it doesn't necessarily go away. So a stressful situation can cause it to resurface. And being placed in a long-term care facility or an assisted living, or having to go to the hospital for an acute care problem can trigger the PTSD. So we have to really be aware of that. Let me just see if there's anything else here that I want to say on this page. And otherwise, oh, one quick thing. There have been studies done that show that if you have a dedicated staff, there's an 80% improvement in care outcomes, like pain, like having catheters, like decubitus. with dedicated staff, again, because they're in a position to pick up subtle changes and engage with that person and brighten their day. Okay, so autonomy, self-determination. If I was a teacher, I would want someone to think of me as a teacher, or if I was a nurse, I'd want them to think of me as a nurse. And then if they want to think of me as a nurse who has a cognitive impairment, that's okay. But to just think of me as a demented person, that would not be okay with me. So it's important that people maintain their autonomy. Emotional ability is seen as a problem. You've all heard of a pseudo-bulbar affect. And after you've had a number of strokes or frontal lobe deterioration, or even with middle and end stage dementia, you can see this. And these are people who cry for no reason. So they might be telling you that they went to a baseball game and how wonderful it was, and they're crying the whole time they tell you that. These people aren't depressed. So treating that outburst with an antidepressant is not necessarily the approach that you would want to take. You can counsel them, because sometimes they're upset. They don't know why they're crying like that, and tell them that that's because they've had strokes, or it's because of this, or whatever the case may be. And you can tell them to try to take some deep breaths, 5 deep breaths or 10 deep breaths. That oftentimes will help them to overcome the crying and the tears. C is important. It means slow down and take time, not only you as the care provider, but allow the person on the receiving end of that to have time to process the information. If you want them to brush their teeth, it may take them a full minute to figure that out, even if you put that toothbrush in their hand and put the toothpaste on their brush. But let them do that if they have the ability to do that. E is for engage. And it's important to engage with all of these people. Let them share stories with you, and you can share stories with them. And the last E is for empower. Explain and give them choices at each step. I, again, remember a patient who was in a wheelchair in the middle of the hall on our unit, and the cleaning cart was there, and the nurse was trying to get by with her medication cart. And she couldn't. And one of the aides came up behind the person. I mean, the intention was, good, to move him out of the way. But it startled him, and he thought he was being attacked. And he started to swing and lash out. And then what do you suppose was the comment made to me? Aggressive assault. And I needed to medicate them. And I said, no, that's not really what we're going to do. Let me show you how this could go down differently. And so I went around to the front of the wheelchair and said, Mr. So-and-so, Carla's trying to get by you with her medication cart, but she can't because the cleaning cart's in the way. Would it be okay with you if I move your chair over a little bit so she can get by? Yeah, Jeannie, that would be great. So, I mean, that's all it took, was just an explanation of why we're doing what we're doing. And 99 out of 100 times, it really is all that's indicated. Okay. So, last few domains. Growth. Connection to things that are meaningful enables growth. So, create caregiver opportunities. I remember in our unit at the VA, every spring they had the residents plant a garden, and there were fruits and there were vegetables, and they loved getting out there, playing in the soil, planting the plants, watering them, and those in wheelchairs were taken out in wheelchairs, so everyone didn't walk out, but they were all given some role in that. And it was wonderful for them to see the growth of the plants and then eat the tomatoes and the other vegetables that were planted. And pets, we always had pets come into the unit for pet therapy, or we had the family bring their pets from home in, and interactions with children and with grandchildren. All of this was so important so that they could continue to interact and grow. And it's very important to remember this next comment. Prisoners are the only other population told they cannot live among us. So when we take people with dementia, and I know that 20 years and 10 years ago, we thought that this was really the best approach, and put them in dementia care units, that may not have been as good an approach as we thought it was, because they need to be exposed to people across the span, people with dementia, people without dementia, people who are ill, people who are not ill, and interact with those people in order to continue to grow. So it's not necessarily in their best interest to take them out of a home environment if there's a way we can keep them there, or an assisted living if we can keep them there where they're mingling with a variety of people. I'm not saying that, you know, in some instances it's not maybe a good choice. I'm just saying to think about it not being the be-all, end-all. And I think I missed one.
Is it
Oh, okay, I'll get it. But I guess I in follow-up for talking about autonomy, meaning, and growth. What do you see from this picture?
cuteness?
Yeah, you can see the smile on her face, and you can see how she's cuddling, and how this little animal is loving being cuddled. And something like that probably changes her whole day for her, just the whole day. Being able to feel unconditional love and give unconditional love to a little animal. And then joy is actually all domains lead to joy. It transcends everything. So simple pleasures like food, song, activities, people, sensory stimulation. So if someone were to ask you, I mean, it's important to know this in anyone that you're interacting with, family member, resident, patient. What are your favorite foods? Would you be able to list your 3 favorite foods? And could you list the foods that your resident really enjoys? Mine are iced tea, salad, and popcorn. I mean, right off the top. If you took those away from me, I would be a sad person. And everybody has favorite foods, favorite music, you know? My father did not like rock and roll, but he loved big band. Loved it, loved it, loved it. And so it's important that we know what makes you happy and then try to put that in place so that all of these people have this. When my father, you know, and one of the things that was important to him, he was so proud of being a World War II veteran. And all of his buddies had been in the war as well. And in our little teeny hometown, the VFW put on a spaghetti feed every Thursday night. And they would go every Thursday night, and he loved being able to commiserate with all of his fellow people from World War II. It was a time for them to connect, to reminisce, to tell stories. That was really important. For my mom, it was important because even though she was 88 when she moved out here and lived to 98, it gave her an opportunity to have a beer and a cigarette. And that's what was important to her every Thursday night. That's the only time she had a cigarette and a beer was Thursday night at the VFW spaghetti feed. So again, that would have been something that made her happy. All important things to know when you're trying to find out about the people that you're caring for. And this picture says it all. I'm sure when these 2 people put their great-grandchildren or their grandchildren in their arms, their world changes. They light up. They just, you know, my mom helped me take care of my grandson until the week before she died. She'd come with me every Thursday morning, get up at the crack of dawn so we could go and take care of Sammy. And the joy on her face was something I couldn't reproduce, but the great-grandchildren did. Okay, so let's get to know the people we're caring for. What are their physical traits? As we talked before, do they have glasses? Do they have a hearing aid? Do they have a blunted sense of smell? Do they have dentures? You know, what are their physical traits? What are their personal characteristics? What are their attitudes and beliefs? That's also very important. What are their talents and hobbies? What are the things they enjoy doing? What was their educational background? High school, college, more? What was their vocation throughout life? And what family information do you have? Do they have family living in town? Is their family all on the other side of the country? Are they divorced? Are they widowed? Whatever. And then you want to know, certainly for your veterans, were they in the war? Were they in the war? What branch of the service they were in? What did they do when they were in the service? What was their job? And was it something that they continued afterwards? And do they have connections with the other veterans, either in their residential care, as we did at the VA in our unit, or do they have VFW spaghetti feed on Thursday night, or do they have other opportunities to commingle with veterans who shared a very, very important part of their life, whether it's Korean War or the Vietnam War or the Iraqi War, etc. Also, you want to know things like, do they smoke? Do they drink? Many, many, many veterans smoke. And remember, during the war, especially World War II, boy, that was really, really pushed. And in the Vietnam War, everybody smoked. In the Vietnam War and some of the other wars, drugs were very predominant. And people who had not been exposed to drugs before were exposed to them. And then drinking, you know, when you went out on leave, boy, that's what everybody did. They tied a big one on. And sometimes that problem with alcohol and cigarette addiction continues on, and you see it in their later years as well. So it's just important to know that, and we need to respect it, especially if they have the ability to still make choices. Even though the choices may not be in their best interest, it's still their right to make those choices, and we have to kind of get our own value system out of the way and let them, you know, kind of predetermine their direction and their destiny. Okay. So again, this is just a nice example of, you know, obviously two younger vets, and then you have the older vet, and they're all sitting there sharing with one another. And I have to tell you, it's beneficial for all of them. You know, the young people learn from the old people, and the old people feel so good if they can share with the young people. So it really meets everyone's needs. So I just want to talk quickly about the differences in how people spent their days in assisted living, long-term care, residential care in the past, and what we're hoping to see more and more of now in the present. So the old school was a recreational therapist, and sometimes the occupational therapist may have had some involvement, and we did bingo, we bounced balloon balls, we folded towels, folded lots of towels, we had movies, we did coloring, we did sing-alongs, and we did puzzles. I have to tell you that most of those things would have bored me to tears, because that's not necessarily what I did in my life. So we need to think not even outside the box, but get rid of the box entirely. So the new school, oh, and I just, in Power's book, he said that two patients were folding towels, and one of the observers came up to them and said, "Oh, I see you're folding towels." And the patient said, "Yes, the nurses bring us towels to fold. We fold them, they take them into the back room and wrinkle them all up, and they bring them back to us to fold again. We're not sure why, but if they want us to do it, I guess we will." And then the observer said, "Well, why don't you tell them that you don't want to fold towels?" And they said, "Well, we're not sure how they'll react, and folding towels is better than a stick in the eye." So, I mean, we may think that we're fooling these people and giving them this wonderful opportunity to fold towels, but really most of the time they get it. It's menial work, busy work that they're not getting any pleasure out of. So, let's individualize what happens in their day. Let's let them garden. Let's offer them a bubble bath. Let's take them out at 5 in the morning and let them see the sunrise, or take them out in the evening and let the sun set. Let them interact with dogs or kids. For my father, we downloaded all the big bands on his iPod. And when he was falling asleep at night, or if it was nap time, or if he was bored, either he put it on or we would have staff put it on for him, and he was in heaven. He was absolutely in heaven. He could have spent 3 hours just listening to big band and reminiscing in his mind what he was doing during that era. Piano, if people play the piano, give them the opportunity to do that. And then provide any other new experiences and knowledge that you can to fill their cup. For veterans, we certainly would, and I mentioned this, veteran support groups. So the VA certainly had veteran support groups. And we had veteran organizations come in and play big band music or do dancing with the veterans. They loved that. And oftentimes we would take the veterans into the grade school. There was a grade school that was right nearby, and take them in and let them perform for the class or interact with the kids in the class or tell them stories. And again, how that pumped them up. They felt so important to be sharing that. So all of those things are meaningful. Bouncing a balloon and folding a towel, maybe not so much. So activities that stimulate the frontal lobe, reasoning, logic, planning, judgment, language, all those things occur in the frontal lobe. So this example came out of one of the resources that I read, and it was from a senior day home in the Bay Area in California. And basically what they did was do a current event for discussion. But they took the veterans and they separated them into 3 groups, those with mild dementia, those with moderate dementia, and those with severe dementia. And for the mild dementia, they came up with a topic like, should money, should water for the community go to agriculture, or should it go to the big cities? Where do we want our water resources to go? And then they provided articles, and the people with mild dementia would read the articles, and then they would put chalkboard there and they'd list pros and cons. Water to the agriculture, water to the city. And then they would have this big discussion about it afterwards. And obviously that was very stimulating for them to read, the studies, read the newspaper, and then dialogue that. For the people with moderate dementia, they put a list on the board of the pros and cons, and then encouraged interaction about it by asking questions that could be answered with yes or no. And that was very doable for the people with moderate dementia. And they gave them time to respond to the question. With people with severe dementia, they did things like bring in dry soil and bring in wet soil and let them feel the difference. They brought in a dried flower and they brought in a real flower and let them feel the difference. And then they had CDs with birds, CDs with the sound of rain, so that again, they were getting sensory, tactile stimulation, the sense of smell. And then they would provide peaches or apples or whatever, so they would get to taste fruit and talk about how the rain helps the fruit to grow, etc. So all 3 groups of people with dementia could benefit from this activity, which stimulated the frontal lobe to some extent, more in the mild dementia and moderate than in the severe. But again, it was such a different experience for them. Okay. I love that. Okay, biomedical model. In the old days, and I remember those, dementia, people, they were sufferers. They suffered from dementia. They were victims of dementia. So it had a very, very negative connotation. It was an institutional, disease-focused approach. Emphasis was always on what they couldn't do, and distress was viewed as the problem and not the symptom. The 3 components to understanding distress. From a medical perspective, distress can be caused from an illness, it can be caused from pain, it can be caused from medications, and there are a lot more which I'll list in a minute. From an environmental situation, noise. If it's really noisy in your environment, that is very upsetting to some people. Temperature, like me, when I walked into this room and it felt warm, That would be really difficult for me. Food, you either don't have enough food or you don't get the kind of food that you want. Tea, salad, and popcorn. And drink, you know, you might not be, or you're thirsty and you don't have the words to say I'm thirsty. You're hungry, you don't have the words to say I'm hungry. You don't have the words to say I'm freezing. Could you bring me 2 more blankets? And so therefore you're distressed because your needs aren't being met. And then experiential, you know, look at the distress as an unmet need and look at the experiences of the person behind the distress. So again, it's not about fixing the behavior, it's about improving well-being. So what does this picture say to you?
Very unhappy.
Yeah, very unhappy, or could be in pain, could be sad, could be mad, could be tired, but we can probably all agree he's not happy.
Hopeless.
Hopeless, yeah, I could see that for sure. So, excess disability is when an individual becomes impaired due to something other than dementia. So you may have an underlying diagnosis of dementia, but if something else is going on, then that will cloud the picture, and you need to be on the lookout for that. Excess disability is often mistaken as dementia or as a symptom of dementia, and therefore interventions for that are behavioral and include inappropriate prescribing of physical or chemical restraints. So these are some of the causes of excess disability, and I won't elaborate on all of them other than to say that medications are often the #1 thing you should look at. So if you see a big change in your resident or in your patient or in your spouse, have they recently had a new medication added, you know, in the last week or the last days or even the last month? That could be the culprit. Sensory deficits I've talked about, you know, if you're not having your glasses on, you don't have your hearing aids in, it's a problem. Untreated pain can really cause disability. We had a patient who was grimacing when we went into the room, and because he didn't have a constant, dedicated staff, and I'm gonna kind of beat that until it's dead, they missed the fact that this was new. This person wasn't normally somebody who just grimaced. And so I went in to try to explore what was going on, and they were on one of those alternating pressure mattresses. But something had happened and it had deflated. So he was laying on the hard metal frame of the bed. And I don't know how long that had been going on, but not good, not good. So untreated infections, and I'm sure you've all seen that or you've heard of that, urinary tract infection, pneumonia, wound infection. They rarely in the elderly have a textbook presentation. And the only symptom you may see early on until it's too late is a change in their mentation or a change in their cognitive status or a change in their functional abilities. So really have to be on the lookout for that, and with all the other ones that I've listed there. Okay, so I'm not going to repeat all of that because some of this I have talked about already. When an individual experiences excess disability, adaptive response is reduced and stops completely and distress increases. And when we talk about a change, I want to give 2 examples. My mom, when she died, was 98 and a half, and you know, she was, in spite of 2 strokes and breast cancer, she still lived independently. She cooked. She took her walker down and back to breakfast and dinner every day. She went out to lunch and dinner with me. She did her own laundry, and she loved playing with the grandchildren. I mean, pretty sharp, intact lady. And I would say something to her, like when we went to lunch, I'd say, "Oh, Mom, I needed to get gas." And I almost jokingly said, "Remind me after lunch to get gas." Get in the car, and I'd be pulling off, and she would say to me, "Honey, didn't you want to get gas?" So I mean, she was still that intact. So one day she said to me, I want to talk to you. And she was whispering. She called me over to the side and she said, those men in my apartment are really scaring me. And I said, well, what men, Mom? And so she related to me that for 2 or 3 weeks, these 2 men had been coming into her apartment, beating her up and sexually abusing her, and then beating up my brother. Now, my brother lives in Pennsylvania, so I knew that there was more to this story than met the eye. So I said, well, let's go up to your apartment. Of course, when we went up to the apartment, the men weren't there. But this is not like my mom at all. And again, this is not a sign of dementia from the lady who told me I forgot to get gas. So I knew something wasn't right, but I didn't quite know what it was. I checked her pills to make sure that she was taking them the way she was supposed to take them, and I checked her blood pressure. I couldn't figure out what was going on. But then it seemed like it was getting worse. So we made an appointment and we took her in to see her doctor. And her weight was up about 8 pounds, and that was a red flag. And I had not noticed any pitting edema when I checked her 2 days earlier, but now there was actually some lower extremity edema. And now when we listened to her lungs, we heard rales. Or fluid in her lungs. And so we did a chest x-ray and she was in heart failure. And so for her heart failure presented as a fixed delusion. These men who kept coming, and she was frightened beyond belief. I can't imagine how horrible it had been for her before she told me about it. So we started her on some medication for her heart failure, very low dose, because you can't blow them out of the water and cause kidney failure and dehydration. And I took her home to stay with me for 3 weeks. And over that next 3 weeks, her condition improved and the men came to visit much less often. And by the end of the 3 weeks, she was not having any visitations anymore, thank God. But I slept with her for that 3 weeks. Even though I couldn't convince her that the men weren't there, because when somebody has a fixed delusion, you can't convince them otherwise. But it gave her some comfort when I'd say, Mom, I won't let anybody hurt you while I'm here. So if the men come, I'm not going to let them hurt you. And then I would have my brother call her every other day and tell her that he was fine and no one was beating him up. And that's how we got her through that. We did not add any medications to the mix. We just simply treated the underlying cause of her excess disability, and she got over it. But really impressive exposure to a very strange presentation of heart failure for me. Another one that I have, just to point out that we don't always have to do something about it, one of my veterans who came to me for a different reason, he had a wound infection. He believed that there was this miniature sumo wrestler that lived on his shoulder. And he took his little sumo wrestler everywhere that he went. To the dining room, to the bedroom, out to the patio. And they carried on this constant dialogue, and he laughed a lot. And, you know, he was just fine with this little guy. And I had been seen by psychology. There wasn't anything else going on but this fixed delusion, and we could not find any physical reason for it. It had been there for a number of years. So again, people came to me and they were very concerned because they thought he was hallucinating, but close, it was a fixed delusion. And they were concerned because he had this sumo wrestler on his shoulder, and they thought that I should medicate him to get rid of it. Now, first of all, fixed delusions don't respond very well to medications, at least not in my experience. But more important, you have to ask the question, is it bothering the patient? No, he absolutely enjoyed having the constant company of this little miniature sumo wrestler. I wish I could have seen it through his eyes. But anyway, we opted to do nothing because it wasn't a problem for our resident. So some of the theories regarding distress: cognitive impairment, functional status, they can't complete or initiate a task and it frustrates them. Under cognitive impairment, they can't understand or process information. Environmental stimuli, too much or too little. You've seen people who are in their room and they just constantly holler, help, 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 help. And they're lonely, they're isolated. They probably want to come out and have some sort of meaningful interaction. And then emotional states as well, anxiety and fear and need to avoid aversive situations. The problem is that when we have people who have distress, and if it's not recognized as that, and if we don't make an effort to find a way to bring well-being back into their lives, then they're perceived as a problem patient or a problem resident. And that's so unfair to label someone like that. And then the staff tend to avoid that room, which complicates it. The family may avoid them because they don't know how to deal with it. It's stressful for the staff and the family, but really stressful for the resident. They get a decreased quality of care, they become socially isolated, and their needs are not met. I just want to remind everyone, if anyone has any questions as we go along, please feel free to ask. We don't have to save it till the end. So what does this picture tell you?
Looks isolated.
Absolutely looks isolated to me. Now maybe they just put her in there for a second after breakfast, but I'm going to read into it. And I'm thinking she's isolated. She's alone. She's staring at a wall, not even at a TV. And she's sitting in her wheelchair. And I can't imagine how awful that would be if that was your existence for an hour, let alone a day or a week or a month. Okay, so 3 areas where distress is most likely to occur. And does this make sense for you? Toileting, dining room, and bath or shower. Why do you think that is?
They're all very personal areas.
Yes. There are areas where your space can be invaded or where your body can feel like it's invaded. So absolutely.
And most of the elderly are really cold all the time.
Yes.
Yeah, we develop a thing that will keep them, enjoy bath or shower. We usually put our towels in the dryer
yes.
for maybe about less than 5 minutes, and then after that we wrap them first, and then they feel hot.
That's wonderful.
And then give them a bath, and then keep them, again with that warm towel.
And that's a wonderful way to approach finding out. And most, as you said, most elderly people are cold all the time. But if you see that, then try to compensate for it to relieve them from being cold. Or, people, now not so much in my daughter's generation, let me tell you, they don't mind wearing something short or having their, we used to wear these high low underwear that go from here to down there, and they wear little thongs, and sometimes they don't even wear those, and they have low cut tops, and they're much more comfortable with their bodies, and they're not as fearful that somebody might see a part of it. But I have to tell you, in my mother's generation, and even in my generation, we don't really like to be exposed, and we don't want somebody to come in while we're on the toilet or come in while we're on the shower or have us be undressed when people are having a conversation around us. So we have to be really cognizant of the era that the person was raised in, and again, what their comfort mode is. I do remember a patient of ours who had been put on the toilet, and then someone forgot him there, and he wasn't able to ring the help button. He didn't have the ability to do that. And I went in and found him, and boy, was he angry, and rightfully so. And he yelled, and he'd been there for an hour, and I know how sore his behind was, and I could only imagine. And the best way to handle that kind of situation is to absolutely apologize and assume complete responsibility for it, and say, I'm so sorry. I can't imagine how awful that must have been for you and how frustrating. and not to be able to get the help that you needed. And let me get you back to bed now and rub your behind really good. And I will promise you that we will try our very best to never let that happen again. What started out to be somebody who was screaming and yelling and aggressive, he calmed right down because I validated his anger. Instead of saying, and we probably heard this, I was busy, I have 10 other patients, you know. That is not the way to diffuse a situation. You have to make an amends to somebody when you've done something that has caused them pain or frustration or fear or any of the above. The other thing that's important is we should create a space outside of the bedroom, bathroom, for things like TV and visitation and reading and activity so that people view their bedroom, bathroom as their private domain and also a place where they go to sleep and not have all those other activities.
I just want to say that in addition to all that, because those are definitely areas where people are not only more aware of their own deficits, but to speak to administrators that might be participating today as a nurse, that, and I've worked in dedicated dementia facilities, that we really need to look at our patient to staff ratio when dealing with people with dementia, and that we absolutely cannot be doing the same assignments to cognitively impaired clients that we do in every other setting, because they need more time for everything across the board, and that causes some of the problems with
Absolutely.
occurrences during these activities. And I just cannot say that strongly enough.
And I
And I
can't
see
agree
it
with
in
you
every
strongly enough.
setting.
Yes, it's absolutely true. If you're dealing with somebody who is not cognitively impaired or having an altered cognitive state, and they're fairly healthy physically, like my mother was, you know, she didn't need anything. But if you have people who have middle and end stage dementia, they require a lot of time and a lot of patience and a lot of love and a lot of moving the environment to meet their needs. And you cannot do that if you were one nurse taking care of 15 or 20 patients. It just can't happen. Or an aide who's taking care of 15 or 20 patients or residents. So that is important. And I'm not sure how to achieve that happy medium of the right staff to patient ratio, but I think we need to continue to push for it. So thank you so much
I
for bringing
think
that.
if it's dementia, it has to be 6:1.
That's
If I
only in
understand,
memory
6:1 is
care.
the requirement.
That's only a secure
And
memory
also
care
in
like that.
regarding to, I just wanted to share, in regarding to the dementia people, I got one lady from one of the dementia, residents, and they said that she needs to be in a facility where it's smaller because she's not eating and everything like that. They will put the food in front of her and then she won't touch it because they said she doesn't want to eat or something. When she was in my facility, I realized she doesn't touch it because she doesn't know how to do it.
Yes,
So you have to feed her.
yes.
Yeah, so that's why it's very important that you know what the capabilities of your patient is.
Absolutely.
Yeah, because she's not eating, she's not getting all the nutrients that she needed because she doesn't know how to do it.
Exactly. And I'll address some of those eating issues in a little while, but Julie?
My mom is in the skilled nursing facility right now as, short term, but we had a recent incident, and this is not in this area, and they had staff on them a high percentage of advanced dementia. So my sister walked in, my mom's baseline, she's driving, she's doing her own shopping. She was diagnosed with a severe case of Bell's palsy, and so some of that, but my sister walked in, her eyes are rolling back in her head. She's oriented only to her first name, nothing else. She's sitting in a shower chair thinking she's in the bathroom, soiled. And she calls me on the phone here, and they're doing vital signs. She's hypertensive, and I said, get her over to the ER. This is a drastic cognitive change. And sure enough, she was so dehydrated, they couldn't get lines in. They finally got a breast IV, which I've never seen.
No.
And a specialist to get her breast. They hydrated her. She was hypokalemic and infected. So I'm talking to the, the nurse administrator and saying,
How did this happen?
being in the education realm too, I said, let's look at this. I talked with the charge nurse first, and I said, okay, let's look at this scenario. Where did it break down? And she could identify that. And I ended up meeting with the director of nurses, and she got at first she was very defensive, and I said, look, this is number 2 sent back to the ER because there was another incident. And my mom became very insecure about their care.
Absolutely.
And so when she wasn't validated, and you do have headaches, and her primary symptoms, she has a flaming, burning tongue sensation. It's just excruciating.
Excuse me, but it's really difficult for people to engage in the long talk. So if you would speak a little louder, they'll be able to hear you. Otherwise, it kind of becomes kind of a distraction.
Okay.
Oh,
So
thanks.
clearly and more loudly would be helpful.
Okay, we don't have a mic that can pass around.
Right, it's in the ceiling.
Yeah.
So, okay, thank you for letting us know. It's an excellent story she's relating. So.
Anyway, she got the picture that her staff had the assumption that everybody has dementia, and they didn't look at the spectrum. There is some mild cognitive things. They totally missed dehydration signs and symptoms, infection. That is very basic to your studies. And she said, I've got to educate them.
Yes.
So, I'm calling regularly, which I'm sure they love.
It is important.
But I'm trying, no one's answering the phone, which says alarms where you can't get any department. It's like, what is going on? So they said, oh, here's your mom. I finally said, give me the therapies. So I'm talking to my mom, and she says, I don't know, I'm confused. My mom never says that. And I says, this is a change. Please go get a nurse to assess her and get a urine. So 4 days later, they get the urine.
It's frustrating.
And a
It's
lot of
very
it,
frustrating.
the dedicated staff, like they had a whole new crew on when my sister came in. No one knew her. I said, you don't have one core person? I asked the night shift nurse, I said, how many patients are you responsible for? And she didn't want to tell me. And then she said, 40 something by herself. She was passing it, she had AIDS.
Anyway, there are issues that need to be addressed, and hopefully this talk will enlighten us so that we can look at making these deficits in the care spectrum better. All right, so escape-motivated behaviors, terminate the situation that the person perceives to be threatening. If they don't want to go into the shower, why do they have to? Give an in-bed bath or bathe them at the side of the bed. Look at the seating arrangements. My father, when he was in the Veterans Hospital after his stroke, they had wanted him to be on thickened liquids and pureed food. Now, how many of you in this audience have tasted thickened liquids and pureed foods? Okay? I would prefer to die than have to have my coffee the consistency of Jell-O and pureed foods. It's unrecognizable, it's tasteless, even though dietary really tries hard to make the best of it, it doesn't happen. And because my father was one of those people who lived to eat, it was the single most important thing that he did. I said, we're gonna put him on a mechanical soft diet so he could recognize all of his food, but we just wouldn't give him a steak. And we're giving him thin liquids. And I signed the waiver that if he developed an aspiration pneumonia, we would not treat it. And to me, that was giving my father a quality of life. Well, the person that sat next to him at the table was on thickened liquids and pureed food. And obviously that was not appealing. So he would reach over and take my dad's peach pie, take my dad's hamburger, and then my father would get frustrated and he'd swing at him. And so once again, my father was aggressive, my father was combative, and we should think about medicating. And, you know, I know this is a while ago, he died 8 years ago, and I really like to think that those terms, we ought to medicate, are no longer in any nurse's repertoire, because nurses, more than anyone else on the healthcare team, carry the power to determine what happens to the patient as far as medication. Most of the time, it's not the physician that says, I think we need to medicate. It's the nurse who says it to the physician. So we really have to recognize that we have the power to change this whole medicating inappropriately scenario and advocate for what's in the patient's best interest. So I just said, why don't you move his table mate to the feeder table where other people have pureed foods and put someone next to him that's on a regular diet? And they did that, and there was never any issue again. So the knee-jerk reaction shouldn't be, let's medicate. The knee-jerk reaction should be, let's look at the whole picture and figure out what's triggering this behavior and what we can do about it. Okay.
It's chemical restraint almost.
Well, yes, absolutely. And the medications that they most often want to give are chemical restraints. And I'll discuss that in a minute as well. But as we probably all, I hope, know in this room, you know, antipsychotic medications are not to be administered to the elderly dementia patient. There is a black box warning on these medications that say if you prescribe them, it may, and it often, most often does, result in death. So I don't know how you can say it any stronger. Don't give it or your patient will die. So I can't tell you how many patients are elderly dementia patients are on antipsychotics. Absolutely unforgivable. And we need to be the ones that turn that around and just put into place the 7 domains and put into place some of these things I'm talking about, which will then alleviate the aggression, the combativeness, all those things that people describe, but don't look at the whole picture. So you can introduce more pleasant and positive experiences, like I talked about the iPod for my dad, and a massage. If somebody doesn't want to shower or bath, maybe if you start out by massaging their feet and then say, oh, well, does that feel good? Why don't we wash a little more? I mean, there are ways to work into it. Sing songs, talk about family members, whatever you can do to bring some pleasantness into the experience. And then you can use embedding to introduce pleasant stimuli. Communication difficulties. If they can't find or use appropriate words, if they can't follow your conversation, if they don't understand your instructions, particularly if you give 4-part instructions, that's not going to work. One thing at a time. I need you to sit down. And if they don't know what that means, you pull the chair out, you pat the chair, and then you put your own self into it. So you demonstrate to them what it is you want them to do. And remember what to say, and they don't remember what to say in a given situation. Sometimes they don't remember what to do in a given situation, and they'll do something inappropriate, like I've seen this happen in church where a wife has taken her spouse with dementia, and he doesn't realize that church is maybe not the right setting for him to reach over and kiss her or pat her breast or whatever it may be. He doesn't recognize that this isn't the way we do things because of his impairment. Okay. So, and individuals with dementia still enjoy participating in social interaction. So they love to ask questions and they really love to answer them. They like to give reasons and explanations. They like to talk about past events. They love to tell stories. My mother was one of the best storytellers ever. Even though she was very shy in social situations, if you'd say, Mom, why don't you tell them the story about the time her whole personality changed? I mean, she became an actress. And they like to discuss current events. So give them an opportunity to do that and say, Bill, why don't you tell the group about the time, or did you see in the news today that thus and such happened? What do you think about that? Give them that opportunity to express themselves. Okay. And there's our little guy from Pearl Harbor, and I'm sure he would want to tell people about the day that he was at Pearl Harbor when it was bombed and what that meant and what he experienced. I'm sure that he would want to share that with someone or talk about history. Okay, so now there are several programs that the VA has started, and all VAs do not have these. Our VA here does not. But many of the community living centers were part of this study, and it was successful, and now hopefully it's going to be put into place in many more VAs. It's called the STAR VA, which is Staff Training in Assisted Living Residences. It was designed by Dr. Linda Perry to address behavioral and psychological symptoms of dementia, like those words we don't like to hear necessarily: agitation, resistive aggression. Consistent and chronic behaviors, as opposed to a one-time episode, because we've already talked about that. If the person usually does this and now today they're doing that, that probably says that there's some acute onset like delirium. If they're not responding to timeouts or logic or reasoning, and I don't even like that word medication on there, but that's part of their description, so I had to leave it there. Advocates interdisciplinary approach, which empowers and educates the staff. So they get everyone from the interdisciplinary team to talk about what the concern is. And then these are the 4 components of the STAR VA program. The old ABCs of behavior, meaning the antecedent, what came first, what was the behavior, what was the consequence, and then you ask who, what, when, where, what triggered it, etc. And then you either change A or you change C. And then they try to increase pleasant events. They promote effective communication and speaking slowly and watching nonverbal communication. Is the patient grimacing? Are they nodding off? Are they drooling? Are they scratching their head? Are they crying? Whatever. And then we have realistic expectations about what we're going to do. So let me give you an example. We had a patient who had been a captain or a lieutenant colonel in the military. And he had been in World War II, and he had been in some of the very bad places with lots of bombings and lots of death and lots of gunfire, and he spent a lot of time in a foxhole. And in our unit, anytime he heard a really loud sound, he thought it was a gunshot or a bomb, and he would go into this foxhole, and this foxhole was going underneath the bed. And then the staff would try to talk him out or cajole him out, and when that didn't work, they would grab his feet and pull him out. Well, needless to say, this became a bit of a problem. So when I came upon the scene one day when they were having this interaction, of course, we stopped their approach. The same thing had happened. There'd been the med cart had banged into the door, loud noise, he went under the bed. So my approach was to crawl under the bed with him. So I went into the foxhole with him, and I talked to him in a very calm, very soothing voice. We talked about what he was hearing, what he was seeing, what he was feeling. And then I saw that he was calming down, and then I said to him, no, I think the firing has stopped. I don't hear any guns or any bombs going off. Do you think we should get out of the foxhole and go and check on the rest of the troops to make sure they're okay? And he said, yeah, I think we better do that. And that's how I got him out. Now, it also helped that he thought I was the colonel. And I don't know where he got that from, but he always called me Colonel Clark. And I went with it. So that I got him to do things because I was the colonel. But once he came out from under the bed, we went to some other rooms and would peek in the rooms, and I'd say, they look okay. they look okay, and then he was satisfied that the troops were okay, and he went back to bed. So I had the staff start doing this with him. And we had to put a little mat under the bed so that if people were going to crawl under there, they did feel like they were crawling on the dirty floor. As we did this repetitively, he became less upset with loud noises because he found support now in the environment, and he knew he wasn't alone. And over a period of time, he didn't seem like he had to go into the foxhole, and the staff could talk him down without having to go through the whole into the foxhole routine. So that would be an example of the ABC.
I have one example to share also. I have this 98-year-old lady.
Talk loud enough so they can hear
I
you.
have this 98-year-old lady who keeps on crying and doesn't want to go to bed. So it was about almost 11 o'clock, and the caregivers called me up, and I went there and see her. And she was complaining that her grandmother, she's 98 years old, and she was complaining about her grandmother, who is existing, of course, that needed a help because the house was burning. She thought about it, that the house of her grandmother was burning, and that she needs to be there to help. And what I told her is that, the firemen are there, she is very safe, the house is okay now, and then tomorrow we're gonna visit your grandmother and see if she is okay. But for now, you can go to bed because she's already safe. I talked to her. So these are white lies sometimes we do to make them really calm.
Yes,
and
absolutely.
she slept that night. The following morning, she forgot all about it.
Yeah, and so that's kind of compassionate misrepresentation, which, really can be all right. If that will appease your resident, then by all means, that's just a fine thing to do to give them some peace of mind.
And can I interject? I think a lot of it has to do with it's a staffing issue.
Mhm. Sure.
When Laura was talking about some nursing or whoever said somebody's dispensing meds to 40 patients or something, or residents. I mean, that person doesn't have time to climb under any meds. And even the regular staff, even if, it can be very, very touch and go. And it's just never enough to implement some of those tremendous opportunities to make change.
It took me 5 minutes to do that. It took the staff 35 minutes to try to get him out from underneath the bed with 3 people. So you have to look at spending 5 minutes to do something that's positive and going to work versus spending 20 minutes or every single day revisiting the same thing. So you have to weigh the pros and cons of that. I absolutely agree that we need to have more staff. I absolutely agree that people with dementia require more patience, more time to allow them to get up and walk to the dining room or go to the sink and shave themselves. Absolutely. But we have to set our sights on that because what we've been doing isn't working. So at some point, we have to figure out a way to do little changes along the way. While you're passing medications, you can have an interaction with each person while you're giving them meds. Comment on something, validate them somehow, ask about their day, comment on their hair. I mean, little things like that make a huge difference, and they don't take any more time out of your schedule. So that's what, and we have to throw the box away and just come up with a new way to try to do what we know is right, given the situation at hand. Okay, I'm not saying it's easy, but I'm saying that I think it can be done. Okay, so I think we got through STAR VA. There's another program called, I'm going to give you a break at free, TAP VA, which is the Tailored Activity Program. And this one is where the occupational therapists assess, identify the veteran's capabilities, deficits, previous roles, habits, and interests, and try to develop activities tailored to the veteran once this evaluation has been done. And it's much like we talked about earlier, really trying to tailor an activity program to what we know would be meaningful to the person. They try to incorporate the family caregivers into the training, and it's designed to improve quality of life and lessen caregiver burden. And again, this one has been trialed at a variety of VAs across the country, not at our VA here. And I don't know what what was put in place for people to meet the criteria of having these programs. Maybe that's something Wendy can check into. Yeah. Anyway. And then EPIC is the Education in Palliative and End-of-Life Care for Veterans. And when I was at the VA, we had a 6 or 8 week EPIC program, 2 hours once a week, and learned this whole education in palliative care. Part of it was the Veterans Oral History Project, where they interview veterans so that they can leave a legacy behind. We need to remember that the World War II veterans are the largest group of dying veterans. And the Korean War, although less well known, 500,000 veterans served in the Korea War. That's a lot of veterans out there. The Vietnam War has the highest incidence of PTSD. And then the Gulf War syndrome and traumatic brain injury are the 2 major problems for veterans of the Persian Gulf War and the Operation Iraqi Freedom War. So these people, when they're in end of life, for whatever reason, we need to remember their military experience, because that will certainly come into play. So you have to understand the influence. Some of them have survivor's guilt because everyone in their platoon died that they didn't. They may have regrets that they didn't go back to save a buddy, and that's really hard for them to deal with when they're also dealing with having a terminal illness. And we have to understand the veteran's cultural experience and how that can be a source of strength and meaning, or it can have a negative impact. Also, the veteran's experience will vary. So if you have somebody who was in World War II, their experience is much different from somebody who was in the Vietnam War. And also remember that many veterans were taught how important it was to be stoic. You don't show your emotions, you don't cry, you don't complain, you don't say that you have pain. And when you're trying to help somebody with a terminal illness, it's very difficult if the stoicism gets in the way of you being able to find out what their needs are, what their pain level is, etc. So it makes it very challenging dealing with veterans. And here's a beautiful picture. You can clearly tell that this person is very thin and very ill, and somebody's taking them out to enjoy a sunrise or a sunset as part of their end-of-life experience. In addition to whatever their terminal illness is, they have severe disabling war injuries. They may have amputee or bilateral amputee or lost vision or hearing. They've had environmental exposure. They may have racial segregation, or they may have racial bias. So they were either used to people treating them differently because of their race, or, for instance, my father, who was in World War II, and in the Pacific, when he got older and after his 2 strokes, and he did probably have a little bit of cognitive impairment, it was very upsetting to have any Asian person come in to do care to him. Now, you could explain to him that this is, 2008, and that this person was, from China, not from Japan. It didn't make any difference. You couldn't logically say that to him. So the best thing we found was, wherever possible, we tried not to put anybody who looked Asian in his room to take care of him. And you know what? The staff was very understanding of that, because they recognized it wasn't anything personal. This was something embedded in his mind from his days in World War II, and we weren't going to fix it, but we wanted to try to give him a quality of care. And then reintegration difficulties. People who have been at war, we've all seen and heard of the Vietnam War veterans that came back and people spit on them and booed them, and how awful that must have been, to see your friends die, your platoon die, you're out there fighting for your country, and you come back and people disrespect you. So all of those issues need to be considered when you're trying to do end-of-life care. Let's take a 15-minute break. Come back at 3:15, and we'll try to buzz through the rest of it.
How'd you decide?
Does she say increase?
No, we can't, we can't that word. We can't, yeah, we're.
We have to call each other.
That's no big deal.
I think an increase in
The conservatory or the chapel or something, you know, or change.
Okay, we ready?
Everybody's got it.
I think so.
So I have one.
Okay,
Okay, just go.
we're ready to go. There were a couple of questions during the break, and I will address those in a few minutes, if that's okay. So, talking about, again, some of the things we can do as caregivers or care providers to improve the quality of life in those persons who we are either living with or caring for. And so this is just a little mnemonic of a dance. And dance is, the D is for don't argue, because most of these people have lost the ability to reason. Some people without dementia, like my first husband, seem to have lost the ability to reason. So, anyway, accept the disease, improve quality of life, okay? Nurture both physical and emotional health. Exercise is really important, and it doesn't mean you have to do yoga or lift weights, but yoga is a great thing to do if you can do it. Creative problem solving, and as I said, don't even just think outside of the box, but just throw the box away. And enjoy the moment. And I don't know if you can all see this. And this is something that you've probably heard before, but I always think that it's worth mentioning. My granddaughter asked me what it was like to be old. So I told her, put cotton in your ears, pebbles in your shoes, put on rubber gloves and smear Vaseline over your glasses. And there you have it, instant old age. And you know, that's very true for many people. If you've got cataracts or macular degeneration and you have diminished hearing and you can't afford a hearing aid, and you've got arthritis or you've got plantar fasciitis, and you've got some problems with the ability to feel due to some neurological difficulties or arthritis of the hands, it's really difficult. And many people who are elderly, in spite of these problems, manage to have a very good outlook on life and be very pleasant to be around and, you know, fill your space with happiness. But it's important to remember that they do have some disabilities to overcome. 3 rules that I think are the most important 3 rules that anybody can ever remember when dealing with any elderly person, whether they're cognitively impaired or not. Don't argue, and don't argue. Now another mnemonic is polite, and it stands for patience, organize and observe, laughter, ignore, tone of voice, and eye and body contact. And I'm just going to quickly go through those. So patience is obvious. Don't be in a hurry. Ask one thing at a time. Say one thing at a time and allow time for it to percolate so that the person can process it and then try to respond to it. Speak slower, not necessarily louder, and make your actions reflect them. So if you have a really irritated tone in your voice and look on your face and you're saying, it's okay, I'm not really in a hurry. You know, that's not really going to try. So what you're saying and how you're looking are not going to come across to the person as being truthful and meaningful. Organize, eliminate distractions, break things into simple steps. Use hand gestures, as I mentioned before. Sometimes written notes when they're still able to read. Write their name on their door. Write a reminder. Put hearing aid in. Rinse toothbrush, whatever it may be. Laughter. I think laughter is probably the best tool that we always have in dealing with anyone, whether it's a resident or a spouse or a child. Smile, use a respectful tone, be cheerful, and give praise for a job well done. I tried to make comments to all of the residents as I would go around, those who were sitting in the hall, or if I went into the room to see one person, I try to say something to the other people in the room. Boy, I like your hair today, Mrs. Jones. That really looks nice on you. And then, boy, that shirt's a great color on you, Mr. So-and-so. Just something to make them know that I recognized them, that I knew who they were, and that they were important enough to me to want to interact with them. And again, if you can see this, it's a prescription for a laughter tablet. Take 1 tablet by mouth every 6 hours as needed for humor. And it was written by, or filled by the pharmacist Laugh-A-Lot. And the generic for this pill was hilarity. So I kind of, I like this because it says a lot. I wish we could give all of us. Yeah. So laughter is so important. This is really important too. Pick your battles. Really ignore something that is not life-threatening or going to cause a problem or harm or violate the safety of your resident or one of the other residents. Unless it's unhealthy or unsafe, just let it go if you can.
I think, and I've said this with my students, you have to ask yourself to what end.
Yes.
If you argue, are you going to win this?
Yes.
You're not. And so.
And do you want to be right or do you want to be happy? That's another one to think about. But I always say, this is my own, when I'm trying to decide whether it's important enough for me to say something, I think, will I remember this in a month? Or will I remember this in a year? And if the answer is no, and it usually is, then I let it go. But if I am going to remember it in a year, then maybe I need to say something about it. So just really pick your battles. And I don't think I gave this example of one of our veterans. For some reason, which shall forever remain unclear, he wanted to put his clothes on over his pajamas every day. So, fine. But his aide had a problem with it, and she would argue with him every single day and try to pull those pajamas off of him. And I finally had to say, how important is this? And who is this hurting? It's not hurting the resident. It's not hurting the staff. If he wants to have his pajamas on, just let it alone. And once they did that, there was never any issue. But again, the patient was labeled as being uncooperative or difficult, and it had nothing to do with that. If somebody wants to do something a certain way, let them do it as long as it's not going to be unsafe or unhealthy. And then I love this one, spaceship broken, needs parts. So if your resident thinks that they live in a spaceship and that it's broken and they need parts, then, tell them you'll help them get them. I had staff members say to me, I don't want to lie to the patient. And I'd say, you don't have to lie, but you can validate their feeling. So if somebody was saying, my wife is coming tomorrow and we're going out on a second honeymoon, and you knew that the wife died 5 years ago, don't say your wife died 5 years ago. But what you can say is, you seem to be really excited about that. So you're validating their feeling. That's not a lie, but you're also not making them grieve all over again for the loss of their wife, okay? So go into their world and let them have whatever it is they think they have in their environment and just validate them. Again, the tone of your voice, talk to people the way you would want them to talk to you. And I can tell you, there have been people in my life, friends, strangers, children, who get a tone in their voice when they talk to me, and it's not comfortable. And I don't like being talked to like that. So I would never want to talk to someone else with that tone in my voice. And I talked before about looking at their facial expression, their body language, the tone of their voice, because that's going to tell something to you. And make eye contact, and wherever possible, body contact, keeping in mind all people don't like to be touched. But if they seem to be inviting you in, I'll hold their hand, I'll tap their shoulder, I'll give them a hug, if that seems to be something that brings them comfort. And if they pretty much give me like the stay away, then I just will try to make eye contact and be kind or friendly with the tone of my voice. Okay, distractions. I use this sparingly because unless they're really trying to get out the door, you don't want to distract them from the thing that they're pursuing, because that is important to them. You need to try to find out why they want to do a particular thing and what you can do to meet those needs, those 7 domains. But you can try to distract them when it's absolutely necessary by listening to music, watching sports, cat therapy, massage, talking about the past, whatever the case may be. When my father had his hip surgery, my dad had never been on narcotics, and they put him on narcotics for the pain. And I have to tell you, it made him really very paranoid. And he was convinced that there was a burglar in the room, and he wanted to get out of the bed, and he could not get out of the bed on the first and second night without a lot of assistance. And of course, I did not want to bring that to the staff's attention, because I knew that their response would be, you know, when you give them Haldol, when you give them Ativan or whatever. But knowing my father, as I did, and he loved sports, and the newspaper was there, I spent the night at his bedside, and I read in the sports page, front to back, back to front, front to back, back to front. That it totally appeased him, and it took his mind off the burglar that was breaking into his little closet and stealing his things. And by morning, that seemed to have dissipated, and we took him off narcotics, and we just gave him Tylenol, which more than controlled his pain, and then we didn't have any issues with that again. But there are ways to distract somebody when it is going to cause them harm. I love this. My wife said, "What you doing today?" I said, "Nothing." She said, "You did that yesterday." I said, "I wasn't finished." You know, everybody doesn't have to do something. Sometimes somebody just wants to sit. They just want to be silent. They just want to look at the sun. They want to hear the birds. And that's very inspiring for them. They get a lot of joy out of doing nothing. So we don't have to make sure that everybody's busy every minute of the day, nor do we have to be busy when we're sitting with them. We can just sit in silence and be silent with them and enjoy that silence together, and that's okay too. You talked a little while ago about what I call compassionate misinformation, you know, where we don't remind somebody that their family member has died, or that they're not going home to their house, or that their mom is no longer here. And that's okay to do that. And we also should step back from a situation. If we as a care provider are struggling, or we see our resident struggling, step back from it and look at the whole picture. And, you know, what am I bringing into this situation that might be complicating things? And what is it that they need that I'm not able to appreciate? And sometimes it means that I would go and get someone else and say, what are you seeing, or what do you think? Because sometimes I lose my perspective and somebody else will nail it, so that's okay. Try to respond to the person's feelings and actions rather than the content of their words, because sometimes their words will not convey what it is they're trying to ask or what it is they need. So 4 R's. Hold on until I just catch up with myself here. Repeating, redirection, reinforcement, and reassuring. And these are really valuable tools, very valuable tools. We have a veteran who, again, for reasons that weren't entirely clear, wanted to urinate in the garbage can that was in his bedroom. And that really upset the staff. But there didn't seem to be anything we could do to persuade him that that was not where he was supposed to urinate. So what we did was each day we moved the garbage can an inch or 2, closer and closer and closer to the bathroom. Then we left the bathroom door open and put it right inside the bathroom. And then we moved it closer and closer and closer to the toilet. And ultimately, we put it in the toilet. And after a period of time, we could take the garbage can away and he would pee in the toilet. But it took that constant redirection, reinforcement to get him to do that. And it was such a painless way to approach the problem instead of continuing to badger him and say, you're not supposed to pee in the garbage can, you need to use the toilet, you need that. That didn't work. So again, step back from the whole situation and figure out what is a good way I can handle this without upsetting the person and also without having staff seem to be upset. Okay. 5 basic goals of care. The patients need to feel safe, and some of this mirrors the 7 domains again. They need to feel physically comfortable, minimize stress, they need to experience pleasure, and that includes sexual expression. You know, when you're in a long-term care setting or residential care or assisted living, you don't suddenly lose the urge for intimacy or for sexual pleasure. That's still a very important part. And so we need to make sure that we give permission and provide an environment where all of our residents can have sexual expression. And that's another whole talk that I do. Experience a sense of control. Again, dignity, freedom, enhanced functional abilities. Okay, I thought of one other little tale. Realistic expectations are part of this basic goals of care. We need to be realistic about what our resident or our loved one can do. And I had this was when I was facilitating a support group for spouses and children who were taking care of their family members who had dementia. And the daughter was very, very, very upset because her mother, who had dementia and was 90, took an hour to eat her meal. And that just really, really upset the daughter. And I said to the daughter, well, that must be frustrating for you to have to sit there and feed her for an hour. And she said, oh no, she feeds herself. I said, okay, well then I guess you have to be right there in the room with her in case she spills or drops things. And she said, oh no, I can go ahead and do the chores that I need to do. And I said, well, I'm really baffled. If she feeds herself and she's happy to be there by herself and you don't have to engage with her during this time, what is the problem? And she said, it takes her so long to eat. And, you know, she really had an unrealistic expectation. And once it kind of pointed out to her how lucky she was that her mother was a self-feeder and wasn't messy, was really quite clean and tidy, and didn't demand constant attention during mealtime, then she saw it as a gift rather than a negative. But she just needed somebody to help her see that her expectation was really quite unrealistic. So I think that's important to point out, not only to family members when we're taking care of their loved ones, but also to staff, because sometimes staff will have an unrealistic expectation.
I had something to share. I had this gentleman, big guy gentleman, that no group,
Can you talk
the
that
group
way?
home can accept it. Okay, so the daughter was really, really upset that I think he needs to be shipped to Idaho because he was a mental thing, whatever, nobody wants to take him. And I said, I'll try. So what I did was get him. The very first thing, he's my husband and he knows that. The very first thing he told me, can I have sex with you? And I said, no. And he said, why? Because you're not my husband. He went to my husband directly and told him, can I have sex with your wife? And he said, no. You know, if other people would get upset, you know, but what we did was give him the love, the care and everything and understanding. And he stayed with us for 7 years. And he even wanted to adopt my grandson. We became a family. And even the daughter was telling me the last 5 years of their lives was the best life.
Wow.
And he passed away in my husband's arms.
He was a veteran.
He was a veteran.
That's a
Yeah.
beautiful
But the
story.
thing is, it's not because he said that,
Yes.
you would just throw him away or something negative. No, we accepted him, give him the family life that he didn't
And you
have.
set boundaries, clear
Yeah.
boundaries, right? And that's important to do. I love this picture because, you know, these ladies are independent. One has to have a little walker, which clearly is using for a little cart to carry things around. And they're having their little outing and they may have some physical ailments that impair part of their lifestyle, but clearly they're just pushing right through it all. I want to just address a couple of the questions real quick that we had. One apparently had to do with PTSD, and I mentioned that the statistics said that the Vietnam veterans have the highest incident. But PTSD is seen throughout all of our veterans, whether they've been in the war or not been in the war. There are things that can cause post-traumatic stress disorder. And yes, if they've had it and it appears to have resolved, when they're in a stressful situation, which could be dementia, it could be placement in an assisted living or a nursing home and being taken out of their home. It could be being diagnosed with cancer. It could be losing a loved one. Any of those things can trigger a reoccurrence of the PTSD. And so then that would need an intervention. And at the VA, we're very, very lucky that we had social workers and psychologists readily available 24/7 for the veterans. And that was really awesome. Let me see my next question. How can you easily provide placement for residents who have dementia when you have limited space? Typically placing them with a companion who has like personalities can be difficult in this case. True. I don't know that you can always do a quick placement because there aren't always facilities readily available with a bed for a quick placement. I don't know that you have to match your roommates per se. I think if you're trying to meet the needs of both people, whether they're very similar in their likes and dislikes or dissimilar, that can be worked around as long as you're trying to meet the needs of each individual. So I don't know if that answered it, but I hope it did. And as far as placement, you know, the last thing any of us want to do to our loved ones is place them out of state or place them down south if we live in the north. And so patience is part of it. If they are a veteran, I would always encourage you to contact the Veterans Hospital. If they are service connected, they can help with placement. And that's really a plus.
And also on group homes, we have to have the endorsement before we can take them.
So enhanced functional abilities And basically, that might be a task of your occupational therapist, and if you have one, I would enlist their assistance with that. And otherwise, I think many nurses know how to do these things, physical therapists as well, so that you build up the handles, you give them non-slip dishes, and you put Velcros and snaps on their clothes, handrails, non-skid floors, walkers, etc., so that functionally they're as independent as they can be. Hello. Oh. Okay. Now, I love these two gals. I mean, they have their mink coats on and their gorgeous white coiffed hair, and they're each in a little scooter, and who knows where they're going, but I'd like to go with them. They just look like they're having a lot of fun. Okay, wondering. Now, I want to call to your attention the term wondering actually is somewhat judgmental, I think, rather than needing directed behavior. Okay, need directed behavior versus wondering. But if I said need directed behavior, y'all may not know what I was talking about. So I'm calling it wondering for the purpose of this slide. But the point I want to drive home is that this is normal. So if you and I got up to walk around because we were tired of sitting, or we were nervous and walking reduced our stress, or we got up to leave a room because we heard a loud sound and we thought it was a burglar, or we saw something new and interesting and we wanted to go over and check it out, like the neighbor's new car, or we were hungry or thirsty, or we had to urinate, so we got up to go to the bathroom or the kitchen, or we were bored and so we decided to go outside and do a little yard work. No one would think that was abnormal, right? But you put someone in an assisted living or a long-term care environment or a residential care, or they're in their home but they have the diagnosis of altered cognitive state. And now if they get up to do any of these things, which for all of their life were normal, it's now considered a problem. So I'm just saying that to put in your mind that this is normal behavior. And so we have to try to figure out how we can allow a person to have this normal behavior without getting into trouble if indeed they have a diagnosis of dementia. So one thing is to daily exercise with them, walk with them, do chair sit-ups. There's a wonderful thing called chair yoga that people can do. So try to incorporate some exercise. Also attempt to pinpoint the cause. If they are thirsty or they are hungry or they do need to go to the restroom, help them with that. And is the wandering a problem? If they're getting up and they're just walking around the circular unit, or even if they're walking to someone's room and walking back out without going through the drawers, is that really a problem? If the other resident doesn't mind, then maybe it's not an issue. We can have fences and hedges so that they can go outside without getting away. We can put locks on the door, bells on the door, have night lights. We can put murals on the door so that they don't recognize that it is a door, or put the lock at the very top, put a mural on the elevator. There are an awful lot of things that you can do to kind of send a person on a safe trail rather than worrying about them getting into problems. If you paint the area in front of a door, in front of an elevator, a darker color with their visual spatial deficits, that will often cause them to stop and not proceed on. Stop signs, you can put stop signs up. And then I want to say another thing. We use bed alarms and chair alarms so that people don't get up and wander inappropriately. But for all of our life, if we heard an alarm, what would that tell us? Run. Run, yeah, fear, fire, burglar, whatever. And so we're putting chair alarms and bed alarms to alert the staff that the person's getting up. But then it might just make them feel much more fearful and that they need to get away. So I'm just trying to broaden your horizons and help you think of what the person in that chair or bed with the alarm might be thinking. And if they want to get up and walk around, and they could do that for all of their life, why is that now not a good thing? So we need to look at all those pieces of this puzzle. Okay, eating patterns. So as dementia progresses, eating changes. So in the early stages, you might have changes in your food preference. You may forget to shop. In the middle stages, you might not recognize food for what it is. You may lack fine motor coordination to eat. You may hoard food in your mouth. You might not remember to chew it. You're easily distracted. You have a decreased sense of smell. And in the end stages, you leave the food in your mouth a lot longer. You refuse to open your mouth, as babies often do. And you have more difficulty swallowing. And sometimes you'll turn your head away when somebody tries to feed you. And you have a loss of appetite. So all of those things can be problems. Also, malnutrition can be a real problem because of all of that. And so some of the treatable causes of malnutrition can be medication. There are some medications that either blunt your appetite, decrease your appetite. Antidepressants, the SSRIs, do that. Emotional problems, depression can cause you to lose your appetite. Anorexia and alcoholism. Paranoia, if your dentures don't fit or you don't have dentures, if you have swallowing difficulties. If you're on a restricted diet, as I mentioned earlier, and you don't recognize your food, or you don't want coffee that tastes like Jell-O, and as this lady mentioned over here, you couldn't feed yourself. All those things can be addressed and therefore improve a person's nutrition. Poor nutrition results in decreased muscle strength, poor wound healing, pressure ulcers, increased risk of infection, and increased postoperative complications, all bad things in an elderly person. Fluids are really important. As someone else mentioned, dehydration occurs very, very quickly in the elderly because as they get older, they don't drink as much. So you can try to make up for that by giving them foods that they might like better that have high water concentrations, like applesauce and Jell-O and popsicles and ice cream and soups. Those are liquids and will help to avoid dehydration. You can give them oral liquid supplements. If you give them before a meal, at least an hour before a meal, it won't blunt their appetite and prevent them from eating and drinking more. And especially true if calories come from glucose rather than fat. And the other thing I wanted to say about that is to avoid Metamucil in these people. In order to take Metamucil, you have to have a lot of liquid on board for it to work. And if you don't drink a lot, it pretty much turns to concrete in your bowel. And that will simply make things worse because now you'll have somebody with profound constipation when you thought you were giving it to them to treat the constipation. So I tended to use things like prunes, increased fluids, or some type of a very gentle vegetable laxative type of thing if somebody had a problem with constipation, and I tended to avoid giving Metamucil. Some hurdles to eating. As they get more into their dementia, they're easily distracted, they lose their hunger, they don't recognize the food, their biorhythms are off, they have difficulty chewing, and as we all mentioned earlier, lack of staff. And one thing that they did do at the VA and also at the nursing home where my father was, they had a feeding table. So the table was kind of circular, and they had 2 or 3 staff members in the middle who would kind of go around and feed, and that way they could actually manage to feed 6 or 8 or 10 people more or less in the same time frame, and the food didn't get cold and they weren't sitting there waiting for someone to feed them. So sometimes I think that type of an intervention is helpful if you have more than 2 or 3 people who need feeding at a given meal. Some of the other approaches: change the environment, the caregiver, or the patient. changes in the environment. You know, if you prepare food close to where it's being served, the smell of the food stimulates the appetite. Therapeutic dinnerware, good lighting so they can see what they're eating, avoid distractions. Sometimes nice soft music is good. And there was a couple studies done that found that if you used red or blue glasses in dishes, people tended to eat more. Not that was
They actually, Alzheimer's Association, they said that a lot of times found with Alzheimer's residents, they don't know exactly what the association is specifically, but they lack the ability to see white, that color for some reason. So changing the
tablecloth
napkins
okay, great.
Visually they're able to
So using
respond better to seeing.
colorful placemats or tablecloths, and of course the push is to try to make the dining area look more like it does at home, so that you have a tablecloth and you might have a floral arrangement. And you know, I don't know if that was as important for the veterans because some of them are used to eating their K rations out of the can during the war, but I still think aesthetically they enjoyed it more when the dining area looked so nice and there was some nice music playing.
Well, if they were Air Force, definitely.
Yeah. Finger foods that are recognizable, frequent small meals, making sure they're sitting up and tucking their chin so that they have less risk of aspiration and remaining upright after a meal and cueing them again. Change in the patient, help them to relearn their eating behavior, make sure their dentures are in place, dental soft diet. Again, I prefer not to put liquids or pureed food in place unless it's absolutely mandatory. And I always talk to the family about the options that they have to refuse that if indeed eating was really important to their spouse or their parent. Making sure they have their glasses and hearing aids, and rituals like many people are used to praying before their meal. And if you omit that, then they're not ready to eat or they need to wash their hands before they eat. So we've talked about this too, but I'm just going to reiterate it. Lack of time, too many residents requiring assistance, short-staffed, lack of continuity or dedicated staff, communication problems between the nurse and the CNA about who needs to be helped with eating, inadequate variety, and educational needs. So staff consistency is important. Have them walk around and look and see who needs help. Like, what's your name over here, my dear, in the purple? Your name?
Benji.
Like she said that the woman who they said she wouldn't eat was because she couldn't eat. She needed assistance with eating. And that's important. And I always thought it'd be great to schedule the staff breaks and their meals before or after the residents ate. And I know that's not always doable, but boy, if it is, then your staff is there during mealtime. And I always encourage family members to come in, family members to bring food in. My father probably wouldn't have eaten at all in the nursing home if I didn't bring him in soup every day for lunch and soup every day for dinner. He loved his soup. He also liked ice cream. So, he also likes Snickers bars.
I also think it's important in our community to remember to read.
Will you talk towards
We
them?
sit and eat with our residents,
Mhm.
so at the mealtime, the staff are eating with
I
them.
love that.
And so I think it's important because they can mimic you and then you can also assist as needed.
In case y'all didn't hear, she's saying it's important if you can do it to have the staff take their mealtime with the residents. Then they're interacting, they're observing for problems, and the staff sees them eat and can mimic that behavior. Great
It's kind of
idea.
like person-centered care too.
Yes.
Like, just like you probably eat, not everybody, but some households, they eat with their family at
Right,
the
all
table, you know,
around,
it's kind of like, well, I'm not gonna eat, and
Unless you do.
generations,
Yes.
cultural differences,
Yes.
I may not eat my meal because you're not eating, why aren't you eating? Do you not wanna eat the food, is the food bad?
And then
You know.
if the person has pain, give them pain meds before their meal. If they have a problem with nausea and they have an anti-nausea medication ordered, give it an hour before the meal so that you increase the odds that they're going to be able to eat. And then there are ethical issues like autonomy, the right to refuse food, quality of life versus preservation of life. Feeding tubes, you know, a lot of studies done that say that the risks of the tube and lack of benefits might mean that maybe that's not the route that you want to go down. And again, the patient's family needs to have that interaction and have the pros and cons presented instead of a hard sell on how important it is to put in this feeding tube. And then quality of life issues as well. Now I want to talk about bathing, and this will be pretty brief. The old model, and some of you have alluded to this in your shares, you know, it was a cold room, it was a dark room, it was kind of noisy. You'd put the patient in the wheelchair or you'd put him in that foyer loop and you'd wheel them down the hall and the cold breeze was flapping on their exposed behind and they were scared. They were absolutely scared and it was uncomfortable. I remember when my father was in the nursing home and they just, again, picked him up, threw him in the chair and wheeled him into the shower and he didn't know what was happening and he would become combative. But if I took him in the shower, which, you know, every daughter doesn't necessarily envision that she's going to shower her father or change his diapers, but I did all of that happily and willingly because he let me do it and he wasn't afraid. And again, it's all in your approach and giving an explanation. So, you know, in the old days, you were either submersed in the tub or you were hosed down and then, you know, taken back to your room and you dreaded the next time somebody was going to show up to do that. In the new model, you know, the shower rooms are decorated with wallpaper and colorful paint, and there's music, and there's different colors for the toilet seat and the tub. And nursing staff fills the tub in advance so the sound of the running water doesn't frighten them. And they undress them in the shower room where they're warm, and they give them a nice warm blanket, and they only expose that part of their body that's being washed. And boy, what a different feeling that is. People are no longer resistant. They're not fighting. And they get choices. Do you want a bath in the morning or do you want a bath in the evening? Most facilities don't offer a choice. And most facilities, you get a bath or shower twice a week, period. You know, some of the veterans would be happy if it was once a month. But some of my patients were always used to showering every day. And it's very, very difficult for them to know they can't have a bath or a shower until Thursday, and this is Monday, and they want it now. So if there was any way to facilitate that, I know that, you know, not always, but if we think outside the box, then there might be. And do bath one night and wash hair another night. You know, you could spread it out like that. And you can certainly do the in-bed bath, which is much more comfortable for many, many people. And all the studies have showed that it gets them just as clean, but it's much less threatening for them. I'm going to kind of jump over that. I think most of that is, you know, taking care you don't hurt them when you move them, because if you have arthritis or you've just had surgery, that can be a problem. And, you know, sing a song or hold hands or do something that they like. Okay, change in the physical environment. I kind of covered this, so I'm going to jump over that. I love this picture of this older woman just on her swing and just so carefree and hopscotch. So activities are great. This is my last part, and just sleep disruption. Sleep is the problem as you get older, and you'll have more and more residents, family members, spouses telling you that they're not sleeping as well. It's really important to make sure the lights are out wherever possible, except for maybe a night light, so that there's not a fall, that the noise is not a problem, that the room temperature is either they're warm enough or they're cool enough, that you're not waking them at 3 a.m. to do an EKG or 4 a.m. to draw their blood. And as somebody alluded to in that other question about roommates' habits, if you have a roommate who wants to stay up until midnight watching TV, then you need to let them know they can go to the TV room to do that, that the light is going to be out at 9 o'clock so that their roommate can sleep. Or you make some sort of a amicable compromise on how you're going to handle noise or lights, etc. Sleep disorders such as sleep apnea, restless leg syndrome, and circadian rhythm disturbances, where you're up at night, sleep during the day, can cause problems. And then medical illnesses. If you're in pain, you can't sleep. If you have shortness of breath, you can't sleep. If you have reflux, you can't sleep. If you're up all night peeing, you can't sleep. And if you're coughing all night, you can't sleep. And so there are things to do about that, like don't give diuretics late in the afternoon or in the evening. I mean, if a doctor says give it BID, I used to try to do it at first thing in the morning before breakfast and then about 4 in the afternoon. I did not give it at 10 p.m. because then you knew they were going to be up all night urinating. So sometimes we have to adjust things to make it so that our patients can get by. Antidepressants, some can cause insomnia. Antihistamines traditionally make people sleepy. So if they're getting antihistamines, they may be sleeping throughout the day and then they don't want to sleep at night or they can't sleep at night. Some of the things we can do is to limit caffeine and tobacco and alcohol prior to bedtime. So if they want to smoke, they want to have their coffee, they want to have their alcohol, then let's encourage them to do it before 5 o'clock. And heavy meals at bedtime are not good. And avoid stimulating activity. You know, maybe you shouldn't watch Game of Thrones at 10 p.m. and then try to fall sound asleep. That might just get you a little too jazzed up. Again, bedroom temperature, and I talked about these other things, but one of the big ones is to avoid or limit daytime napping. So if you see that somebody is nodding off throughout the day, then that person probably needs some type of a meaningful activity to keep them awake. Bottom line, in conclusion, goals of care must always be directed towards providing or increasing quality of life and enhancing well-being. Thank you. Did you want me to do questions now?
Yeah.
Or, yes, okay, so if there's anybody out there or here that have any questions, I'm happy to take those, and then we'll have a short break before our next speaker.
And I would recommend you go to the places the people who aren't in the room, because the people in the room
Yeah.
have opportunities.
Okay. So if anyone out there at Elko, Las Vegas, or on your own private computer have a question, I believe that Troy and Patty have let you all know how you can ask away.
So you can unmute yourself with the icon in the lower left corner, or you can send it in via the chat function.
So it looks like Natalie has the microphone, so
Okay.
very good. Natalie, do you have questions or comments?
Las Vegas does not have any questions or comments.
Okay.
Thanks. How about those of you in Elko? Hang on, we're getting the unmute, so give us just a second. Do you have any questions for the speaker? Anyone from Elko?
You're making my life very easy.
No? And I think you answered the other questions already.
Yes, I did. Okay, then you can
Any
have
questions from those on the Zoom system?
any Zoom questions? No? So do we want to give them a break till 4:15?
Yeah, Fred's in the audience, so
Oh, Fred, so why don't we just let Fred
so
go?
we'll take a 10-minute break so that Fred can get set up.
Okay.
Good afternoon. My name is Fred Wager, and I'm the Deputy Director for Nevada Department of Veteran Services, and it is great to be here today. First of all, I want to thank Wendy up in Reno, and Director Miller for helping sponsor this through our VIC program. Great program, and I'll talk about that a little later as well. But we'll get started this afternoon. I'm going to be talking about the benefits you may be able to help veterans get so they can receive even more care than they possibly are now. So I'm a little intimidated because I know what your jobs are, and I know how much schooling you've had and how much education, and so you're way above me, and I'm just here to give you some information, and hopefully I can do that to the best of my ability. First of all, before I begin, can we turn that down just a little bit more? It's getting just worse. There we go. Thank you. Has everybody heard the theory that if a butterfly flaps its wings at a certain place or time, that it can eventually cause a hurricane across the globe? Isn't it? How many have heard that theory, right? So using that theory, I just checked. Las Vegas is at 101. Reno is at 86, and Elko, you're at 92 degrees right now. So what I'd like to happen is tomorrow morning, I want Reno and Elko, when they come outside in the morning, to face Las Vegas and blow as hard as you can. Okay, does that work? All right. So anyway, Dr. Clark mentioned a lot of great topics, and I noted a couple of them. First of all, I can tell you that I fold towels now, and I have no plan to do it when I'm in elderly stage, so you can forget about that. And I noticed she just mentioned about the dining room arrangement and how that can affect people as well. And for the veterans, as long as it's orderly and clean and it's good chow hall, we're very satisfied. So if you got that in your facility, you're good to go for veterans. I want to talk about programs and services just for a minute that we have before I get into how you can get veterans higher benefits. We do have the VAST team. That's our Veterans Service Officers. It's actually Veterans Advocate Support Team. And so we have that. We have offices in Reno, Elko, Las Vegas, and we do have offices in Fallon and Pahrump as well. So we have them scattered all over, and we're looking to do more and more outreach. And we do go to other towns as well with our Rover program, so it's pretty good. We are getting more involved with Women Veterans Program. Pamela in Reno is our chair up there, our coordinator, and is doing a tremendous job. We actually have an MST conference coming up here in Las Vegas for CEUs as well. So if you've heard of that and want to attend, I hope you will. We have the Nevada Veteran Advocate Training Program. That's where people can actually receive training to become veterans advocates. They learn all about veterans benefits, and that way they can assist their neighbors or their friends who are veterans to file claims and get those to our service officers, so our service officers can submit those to the VA. Of course, everybody's familiar with the Northern and Southern Nevada cemeteries. We just held our Memorial Day programs there and had really good turnout. We had about 3,500 people in Fernley for Memorial Day. So a great audience up there, a great attendance, and about 1,500 down here in Boulder City. So appreciate everybody that came to those. And of course, Wendy's up there. Wendy, wave your hand. Yeah, there you go. And she's in charge of, she's the Deputy Director of Health and Wellness. And she's got probably the hardest job in the whole business, because she is in charge of any wellness programs, including the nursing homes. And of course, we have the Southern Nevada Nursing Home in Boulder City. And yay, we just got approved. The budget went through for building the Northern Nevada home up north in Sparks. And so we're very excited about that. And so for the next few months, we're going to be very busy, or she's going to be very busy. Her and the director, I get to stay down here and work with veterans, so I'm happy. But they do have, I'll mention the grounds breaking is July 17th. Is that correct, right? Yep, July 17th. So if you're up in the Reno area and you can stop by that day, July 17th, we're going to do the groundbreaking and get the home started up there. And then we, of course, have the Veteran in Care Program, which is the sponsor of this presentation today. And I'll talk a little bit more about some of the other things we do in the Veteran in Care Program, and hopefully you'll do them in your facilities. So what can you do for the veterans in your facilities? There are two things, I'm going to talk about them both. One is, and Dr. Clark mentioned, service connection. Let me just describe what service connection is. Service connection is when a veteran has a disability and it is due to either something that happened in service or because of service. I'll give you an example. The veteran is in combat and he is injured, obviously that's a service-connected disability. As long as it's a ongoing condition, a chronic condition, that can be service-connected. The other kind is maybe you don't have anything to happen in service, but take our Vietnam veterans who were exposed to Agent Orange if they went in country. And now they have diabetes, ischemic heart disease, Parkinson's. All of those are called presumptive conditions. Presumptive means if you were in Vietnam on the ground, we presume you were exposed to Agent Orange. And if you have that condition, it's an automatic grant of service connection for that disability. Okay, so didn't happen in service, but it happened because of service. So that's the difference between those. There's direct, happen in service, or presumptive. The other one is secondary. Same veteran has diabetes, and he files a claim for that. He gets service connected for it. And now he's got peripheral neuropathy and erectile dysfunction and hypertension and all these other secondary conditions. He can file a claim for that as well, and he can get granted service connection for those conditions. If they're in your facility and they have these conditions and they continue to get worse, you should make sure they get some help. You can contact our office, or you can contact one of the veteran service organizations within the state. If you're in a small town, Elko or Ely or Pahrump or one of those other towns that has a VFW, American Legion, DAV, whatever those organizations are, many of them have service officers that are certified to take claims. And so if you are in one of those towns, make sure you build a relationship with either our office or one of those organizations. So if you have a veteran, you can say, hey, we need you to come out here and help us get this veteran more benefits if possible. One of the things that's really big, especially in assisted care living, long-term care, nursing homes, whatever the facility, eventually they can get to a point where they need aid and assistance. Now there's some criteria for that. The service-connected veterans have to have one disability at 100% by itself in order to be granted aid and attendance. And so there's a couple forms that need to be filled out, and that's why I say build that relationship with the Veteran Service Office or with our office. We can help out, come out and fill them out. They're not that hard to fill out, so if you want to help the veteran yourselves, please feel free to do so, and then get that to our office, and we'll be happy to submit them. The 2 documents you'd have to have, or 3 documents for aid and attendance, is what's called a VA form, VAF, VA form 21-526EZ. It's a real easy document to fill out. That's why it's called easy, a real easy document. The other one for aid and attendance is 21-2680. And I apologize for not having the forms here, and I'll change that the next time. But those are really easy to get offline. Do a quick Google search and you'll find them, yes. The first one was VA form 21-526EZ. That's just a regular claim form, and you got to have that. The next one is VA form 21-2680. That's the aid and attendance form. Then, in order for us to help that person, they need to appoint us as their accredited representative, their power of attorney for VA claims. And so the form for that is 21-22. Okay, but as I noted before, it doesn't have to be us. We like it that way. We want to help veterans as much as possible. But if you're in the smaller towns out in the community and we're not readily available, and you have a VFW, American Legion, or DAV in your town, feel free to use those 2. They can help out. Okay. Dr. Clark mentioned that veterans love to tell stories, and they do. So if you have time, and I know you're all busy, but if you have time, please visit with the veterans. They love to tell stories. They may not shut up, but they love to tell stories. So please, and boy, I tell you what, some of the stories they tell are just amazing. I've talked to veterans who were at Pearl Harbor. I've talked to veterans who were there at D-Day, and I've been around doing this for a while, so I've gotten a chance to talk to a lot of those veterans, and it makes you appreciate what those veterans do. So when you have veterans in your facilities, please take the time to listen to them. Dr. Clark also mentioned PTSD, and I know this isn't so much about getting them increased benefits, but one of the things I noticed, and maybe Dr. Clark can maybe answer a question on this a little later, but one of the things I noticed with veterans coming into my office over the years was as they got older and retired, they had more time to think. And the more time they had to think, sometimes that kicked off some things. And so the PTSD, they might have had it all along, who knows? But at that point, it started to manifest itself. So be cognizant of that. When they're in a changed environment, like she said, the whole thing changes and the stress level goes up. And so that can really be a factor with veterans, especially with PTSD. So please keep that in mind. I mentioned that there's two types. There's service-connected. There's also non-service-connected pension benefits. What that means is the veteran has disabilities that are permanent and total. In other words, totally disabled by the VA. But they weren't caused by military service. They just happened to, maybe they were in a bad car accident and now they're totally disabled. They can receive a non-service connected pension, but there's some catches here. It's income-based, and we're going to talk about those incomes. They're income-based, and they're household income, not just the veteran, but if he's got a spouse or kids at home, anybody that's making money in that household, that money counts against the pension. So that's got to be considered. They have to have 1 day of wartime service. So doesn't mean they had to be in war, just means that we have wartime periods. Okay, right now we're still in the Gulf War period. Okay, that has not ended yet. So we had the World War I period, World War II, Korea, Vietnam. Vietnam era ended in 1975, and then Gulf War started in 1990. So if they were in the service between that period, if they were in the service, say, 80 to 84, and now they have a disability that's permanent total, they wouldn't qualify because they didn't have that 1 day of wartime service. So you got to keep that in mind. But that's why it's important to talk to your veterans. And like Dr. Clark said, get to know them. You know, find out about them. Find out where they were, what they did. They like talking about it anyway, so you may as well ask, right? So they have to have that. They have to have an other than dishonorable discharge. I didn't say other than honorable, I said other than dishonorable. So there's all these honorable, general, all kinds of different discharges. The bottom one is dishonorable. Okay, if they have a dishonorable, they're out of luck. If they have anything other than dishonorable, they're still eligible as long as they meet the other criteria. They have to have that permanent and totally permanent and total disability, and then limited income, which we're going to talk about. And then just in the last few years, Congress passed a law that says if they're 65 years or older and they meet the other criteria, they can also get it. So they don't have to be permanently totally disabled at that point. They're 65 and older, maybe they're in your nursing home, they had one time 1 day of wartime service, they can still receive pension if their limit on income is low enough. The form for that is VA Form 21-527EZ. Remember the other one was 526 easy? So compensation is 526 and pension is 527. Another one that's easy to get off the internet, okay? You may need to assist them in filling out the forms, but again, contact our office or one of the service organizations. They'll come out and help, okay? So what's it mean to be eligible for aid and attendance if you're not 65 or older? Either requires aid to perform everyday living functions, you're bedridden, you're in a nursing home, assisted living, due to mental or physical incapacity, or you're blind in both eyes. So that's if you're not 65 yet. If you're 65, file the claim for pension. So let's talk about the income, because that, a lot of times that disqualifies them because they make too much. A veteran with no dependents at all, can only have an income of $12,907 or less. $12,907 or less. And every dollar he makes, so that's the maximum pension could be. So every dollar that person makes, that veteran makes, comes off that. So let's say they get $9,000 in Social Security income. Not Social Security disability, but Social Security income. Then they'd only get $3,907 in pension. Yeah, it's very low, yes. I can repeat the question too if you want.
Oh, yes, please. I do hospice work, and so I was more with the elderly. When were these major cutbacks?
When was what?
The major cutbacks to this with like aid and attendance.
Okay, this is without aid and attendance, and I'll get to the aid and attendance numbers in a little bit. But these numbers have, I swear, have actually gone up periodically with the COLA increases. And so they were much, much lower. Understand this started in the 1940s. And so it hasn't gone up much, but it's gone up a little bit each time there's a COLA increase. This last COLA that the veterans got for their compensation and pension was 0.3%. Wasn't even 1%. It was 0.3, a third of a percent COLA increase. I won't even get on that topic, okay?
I will apologize for Randy and must be my family. We are sorry.
Yeah. She asked exactly when did these take a cut, and they actually haven't. They have gone up, but it isn't much. So a single vet, this is for just pension, not with aid and attendance, is $12,907 max. With one dependent, and keep in mind this is household income we're talking about, with one dependent, it's $16,902. Okay, so you're probably looking at maybe a couple that are in a nursing home and don't have any income. That could be the case, and then we can help out there. Now let's talk about aid and attendance. That veteran with no dependent, that now goes up to $21,531. Okay, so about $9,000, a little short of that. Okay, so a vet with no dependent that now is in your facility and needs aid and attendance and doesn't have a service-connected disability that causes that pension, aid and attendance, $21,531 a year income would exclude any benefits. If it's lower than that, they get the difference, okay? If you have one dependent, that goes up to $25,525. Now, one caveat to that, and again, that was $25,525. One caveat to that is if they have medical expenses that are 5% of MAPR, I'm trying to think what MAPR stands for, I can't think of it. So if somebody knows, give me a shout. But if it's their maximum allowance pension rate, that's what it is. Thank you. Sometimes I get it. They can deduct it if the medical expenses exceed 5% of their maximum allowable pension rate, then they can get $645 on a regular pension, $845. If you have that much, then you can deduct that from the income. So it gives you a little bit more. It could raise your pension a little bit. Okay? So those are compensation and pension, and a lot of people get the two confused. And again, compensation's for service-connected disabilities. Pension is for non-service-connected disabilities. Okay? The main reason I'm here today is if you have somebody in your facility who is not getting all the benefits they deserve, then we would want you to contact us so that we can help them. Because at many times, they may be limited on the amount of care they can receive in your facility because they don't have the income to pay for it. And this could be the difference. And so we need you to help those veterans get to us. We can come to them, okay? They don't have to come to us. We understand the situation they're in. We'll come to them and we'll help fill out the documents. We'll get them taken care of, okay? Just make sure you contact us. Before I ask for questions, I did want to mention one other thing. This is sponsored by our VIC program, our Veterans in Care program today. And we have what we call Veteran in Care presentations that we do at facilities, nursing homes, assisted living, long-term care facilities. And we come out, and this was set up by Wendy and Kat, so thank you again, Wendy. We come out and we actually will present certificates and pins to all your veterans and spouses of veterans. We've actually done children. I was at one where one of the aides in the nursing home had a father that was in the military, had been in the military and passed away, and we gave her a pin. And so we give the vets certificates and pins and family members pins. And they are Veterans Heroes pins. And they're really, really nice. We do a full celebration. We start with the Pledge of Allegiance. We do honor guards. We have volunteer honor guards. My good friend back here has been in, how many have you done?
I don't know.
A lot. But we come out and we do the whole presentation and sing the national anthem and a lot of different things. And then we also have one lady that does the bugle, and we do taps at the end if they want. A very nice presentation. How many, I'll need some hands, in Reno, raise your hand if you've had that done at your facility. A couple, I think. Okay. And Elko, have you had any up there? One? Okay. And how about in here? Las Vegas. Looks like we got some work to do. Yes? All right. All you got to do is contact us. We sent letters to every facility in the state, 400 and some facilities, I believe it was, Wendy. And we have done over 100 of them so far. Not everybody responded. So if your facility wants that, please contact us so we can honor your veterans, okay? Hopefully you have an area in your facility where you put up veterans pictures or whatever. We see a lot of that when we go out there. They have pictures of maybe what they look like now and what they looked like when they were, you know, and at the end of World War II or in World War II where they were young folks. But we hope you would do that. So with that, I'm going to open it up for questions. Both ends or all ends? Elko, Reno, anybody here in Las Vegas?
Does anyone have questions there? Oh, Jeannie, yes.
Yes, Jeannie.
I wanted to thank you for the promotion, but I wanted to clarify that I am a retired geriatric nurse practitioner. just for the record, but thank you so much.
Oh, well, you're in medical, so I figure you're a doctor. So we call all our medics in the military doc. So once you've got a medical badge, you're doc. So congratulations.
Wendy, do you want me to share that video?
Let Fred know that we have it. Fred?
I texted.
Oh, Fred, we do have a Vic video. When questions are done, we can go ahead and show for the close.
Okay, great, because that is just an amazing program. I will be honest with you, I just retired from the VA, and I retired April 30th, and May 1st, I was named Deputy Director for Nevada Department of Veterans Services. I was actually named before that. When I was first hired, Kat says, when can you go to work? And this was about the 1st of April. And I said, well, the VA likes to retire people at the end of the month. I was thinking May 1st. And she goes, no, I need you before that. And so I actually went on leave with the VA, and I couldn't get paid twice. So I came in, I volunteered as Deputy Director from April 15th to the end of the month. And then I became the full-fledged Deputy Director. So I'm fairly new at this, but I've been in the business for about 17 years. Between being a national service officer for another organization and then working for the VA and doing the work there. So I really enjoyed it, and I love coming to these because I think the communities need to know that they can help the veterans. You know, don't leave it all to the veterans, help them because they need that, and especially when they're in facilities like yours because they don't always know what they're entitled to. So the more people we get to these, they can say, you know what, you told me you served in Vietnam and now you've got Parkinson's disease. Did you know that's a service-connected condition for Vietnam vet, or ischemic heart disease? You know, a lot of times they'll develop some of these while they're in your facilities because they're in for something else. So it's very important that you know that if they're a veteran, they should be in touch with a veteran service officer, and we can make that happen. So unless there's any other questions, I will.
I was just going to ask.
Yes.
Do you have
Yeah. Do I have any brochures?
Brochures,
And
business
Wendy, please don't tell Kat, but I forgot mine.
I'll be found up here, Fred.
Okay, we will get you some. Okay, one way or another, we'll get you some brochures. If you can, just let me know who we can send them to. And
Actually, if you send it to me, I will go ahead and email everybody the presentation that Fred just presented, as well as PDFs of those forms. So you'll have all that
and then we'll get you
email.
We'll get you flyers. The group here, are you all from Las Vegas proper? So feel free to stop by our offices too. We have an office in the VA hospital. The VA benefits office is on first floor. And we co-mingle with those folks with the VA, and we're right in the back of there. Feel free to stop by and pick up anything you want, or talk to a veteran service officer about how they can help you. Alco, you know, you can go to the office up there and feel free to pick up any brochures or anything you'd like. And thank God for Wendy, she provided them up there. So thank you, Wendy. Any other questions? Yes.
Wait 1 second, I get your mic.
I work in multiple states. Is Vic in every state, or is it strictly?
No, this is a great program that started right here in Nevada. Wendy, I'll let you address that some more as far as how that might spread across the nation.
Thanks, Fred. Actually, it was an initiative fostered by our director, who said, we don't know where our veterans are. So I launched the outreach a year ago today, actually, or a year ago this month. And that's where we started to get the response back. But what we're going to be doing is presenting this at the National Association of State Agency Directors and actually submitting it for the Lincoln Award for Innovation, which will make it packageable, and it will go out to all states. So we hope it goes viral, and it is in all states. And the beauty of the program is not only the recognition, but it's also the education arm. that we're trying to do as well, and making sure our vets know about their benefits, like Fred said. And thanks to Patty and Jeannie, they are part of this educational free offering that we're doing, veteran-centric, but also with the overlay of dementia. And then we have another program we call Bravo Zulu that we're doing as well. So anyway, our whole intent is to have people have the tools and the access to information, whether it be benefits or whether educational opportunities. And finally, the recognition of our vets. And we'll close with a video. We just produced these, they're still raw. I can't remember if the one we're going to show you is at the veterans home, but we also have a community-based one of 40 facilities that went out. So I'm not sure which one's coming up, but you'll get the essence of the honoring of our vets. So thanks a bunch, Fred.
But you can see why we're proud of Kat and Wendy. I mean, that's just a great program. It's honoring our vets, and that's what we should be doing. Yes. Please. Hold on, okay, go ahead.
I'd like to make a suggestion. I'm a Navy veteran and also a veteran's wife, but I do the small homes.
Oh, yes, Becky, you're there.
Yes,
Yes, I am. I do the small homes with a friend of mine who's also a veteran, and as many as 12, as few as 1. And it's interesting to see that the reaction these veterans have, it's amazing. They can't believe that someone would come and recognize them. So I would say to you, all of you people who have small homes or only a few veterans, have us come out, because we will. It's important to us as well as them, especially us, those of us that are vets. So I would urge you to get those guys recognized. We enjoy doing it, and it's amazing the reaction you get.
Thank you, Paige.
Yeah.
Yeah, it's been amazing, and just this last month we did one. You know, you figure the veterans in the veterans home get recognized all the time, but you know what? We just did one. Well, I think it was 180 people all together, something like that.
Yes.
And we had 80 that we presented pins and certificates to. A little bit of a zoo because we had 3 teams, and Wendy was reading off the names, and we were running over there. But you would have veterans in tears because they'd say, we had one elderly gentleman, I wish my mother was here. Sorry. I wish my mother was here so that she could see I was important. That does rip your heart out. You know, I mean, it's very emotional, but it is so worthwhile to do for your veterans. So please go home, talk about it amongst your team and see if we can do that for you, okay? We'd love to do that. With that, Wendy, I'll close unless somebody else has other questions. I'll close and you can run the video of the presentations we've done.
Okay, thanks, Fred.
Wow, I'm not sure there's a dry eye in the house here in Las Vegas.
Yeah.
So just, did you have anything to close?
No, just in closing, that was, we've been out, as you heard, to close to 90 facilities. We've shot a lot of iPhone videos or iPhone programs. I got a hold of a friend of mine who's a videographer and said we need to pull all this together as best we can. And so you saw your facility was there. There was one lady in that clip that was a 107-year-old lady vet. Yeah, you recognize her.
I love the pictures, the music, I mean, all
Didn't
that
he
was
do?
beautiful.
Yeah, it just catches the feeling. And to Fred's point, you saw him choke up when you talked about the certificate. Let me tell you, when you stand in front of these vets and you thank them, and they tear up, and it's just, and you shared earlier that you have a gentleman that's carrying that certificate everywhere. And our wonderful Peggy, that you heard her voice, is a volunteer along with Carolyn Whaley, who do go out to the small homes for us. And we get feedback back from her, and she will say that the vets will say, I thought I was forgotten. Or I'm going to put this on my wall so people know I was important once. Or, it's just, whoa. It really consumes you, as you can tell. But it's just such a privilege. We've honored over 1,000 vets now, actually 1,074, and 400 of those have been World War II. So, yeah, it's been pretty cool. So, and we're going to
get a pin and a certificate.
Yeah, they get a certificate and they get a veteran Nevada Heroes pin. Wow. So anyway, thank you, Patty, for being able to pull that up and Todd for us. So it's, and all of you for your commitment to learn more about not only veterans, but those that are compromised in their aging process. And with the great information that Jeannie gave us today, I think we can all do our job better. So thanks, Patty.
So just a reminder to complete your evaluation. That's what will prompt your certificate. I think about 7 left for those who were on the sign-in sheet.